Can we start,
Hello?
sir, with you? Ma'am, good
Yeah.
afternoon. Sir, ma'am has given permission to start. If it's okay with you, we'll start and ma'am will join.
Yeah, please. I think yes, time
Thank
is
you.
already.
Thank you.
Yes, ma'am. We will live. We are live. We are live.
You like? Good afternoon, everybody. At the onset, I would like to welcome each and every one of you on behalf of ESI to this fantastic webinar on Ramadan and diabetes. We are exactly 1 month away from the very auspicious month of Ramadan, where we know that our Muslim patients are going to be fasting. And I think it's very, very important with new data coming in, with new technology, for us to understand as to how we can possibly, whether first of all we can allow our patients to fast, and B, how it would be possible for us together with them, because we are in an era of conversations, shared conversations, of shared decision making, as to how possibly we can make this experience a much more safer and spiritual experience for them. And it gives me great pleasure to introduce two very, very upcoming and budding endocrinologists from PGI Chandigarh. Can I have the introduction slides, please? Who are going to be the rapporteurs for the day. It is with great pleasure and pride. It always creates a lot of pride in me when I'm introducing Generation Next. Is Dr. Amal Shahryar, who's a senior resident from PGIMR Chandigarh, and who's done her post-graduation, undergraduation from Aligarh. I would also like to introduce her colleague, Dr. Siddharth. Next slide, please. Siddharth Madhad. Forgive me, kids, if I've not got your pronunciations quite right. I've just nicknamed Siddharth as Sid, who's the senior resident who's done his undergraduation, post-graduation from Jamnagar and BJ Medical College, Ahmedabad, and is currently pursuing endocrinology from, again, PGIMER Chandigarh. So over to you all to carry the meeting forward.
So thanks a lot, ma'am.
Thanks a lot, ma'am, for the introduction. Good evening, respected chairpersons, eminent faculties and delegates. As ma'am has already introduced, me and my colleague will be hosting this session. And on the behalf of Endocrine Society of India, we feel honored to welcome you all in this webinar. The topic for today's webinar is Ramadan and diabetes. And in this setting, actually, I want to just highlight a survey which was done in 2021 in Turkey of around 262 family physicians. And it was shown in that survey that only 22% of the family physicians were aware of any sort of guidelines for fasting and diabetes. And only 10% of them acknowledged to have ever referred to these guidelines for the management of the patients. So we can see that there is a big lacuna in this arena, and with this webinar we hope that we'll be able to bridge this gap about the practices surrounding fasting and diabetes. So we are privileged today to have President of Endocrine Society of India, Professor P.K. Jabbar sir, with us, and along with it we are honored to welcome our chairpersons, Professor Singh sir and Dr. Sarita Bajaj ma'am. All of these personalities need no introduction from us. And I request Professor P.K. Jabbar sir to please address the gathering and start the event. Over to you, sir.
Good evening now. Assalamu alaikum wa rahmatullahi wa barakatuh. Now it's dear friends, I'm extremely happy to address this audience. Now, endocrinology, Endocrine Society of India, everywhere, even any place for that matter, it's very active, especially pre-Ramadan time. It's the right time to conduct this type of webinars, especially to educate public regarding Ramadan and its modification of your diet, modification of your treatment, everything that should be done during pre-Ramadan time. If I'm quoting words of Sahaba, see, they very clearly said, Even if you go to China, you get information. Now, even your house, you are getting information through this type of webinars. It's very useful. One of my friend was telling, all these webinars have really changed our educational system. Even the people are very happy to attend this type of webinars for enriching their knowledge in various fields of medicine. So I wanted to congratulate the persons involved in this activity. And I hope everything will get benefited with this type of webinars, and we'll get a beautiful and smooth, very healthy Ramadan fasting this time, of course, in future years also. I thank and I convey my best wishes to all faculties, delegates, office bearers, whoever attended this meeting. Let me conclude. May Allah subhanahu wa ta'ala bless you. Thank you very much. I'm signing off. Over to ma'am.
Thank you very much, Jabbar. Thanks for those very kind words. And welcome, Bajaj ma'am. Thank you for logging in. And I would request Amal and Dr. Siddharth to please introduce our chairpersons for the day, Dr. Singh sir and Bajaj ma'am.
Good evening, ma'am. So our chairperson for the day is Dr. Sarita Bajaj, ma'am. Ma'am is MD Medicine, DM Endocrinology from AIMS, New Delhi, and ma'am has FRCP, FICN, FRSSDI, FUPDA, and FICP. Along with that, ma'am is consultant endocrinologist, former director, professor, and head of medicine, MLN Medical College, Prayagraj. Ma'am is founder, president, South Asian Federation of Endocrine Society 2013 to 2015, president of Indian Thyroid Society 2022 to 23. Ma'am is president RSDI 2016 to 27. Ma'am was also president of Endocrine Society of India from 2010 to 2011 and editor-in-chief ESI Manual of Endocrinology first and second edition. Professor Sarita Bajaj Oration established in 2018 in RSSDI UP chapter, and Professor Sarita Bajaj Oration established 2021 in Cardiac-On for outstanding contribution in medical education and research. Lifetime Achievement Award was for outstanding services in the field of diabetes and metabolic disorders. Lifetime Achievement Award for exceptional contribution in empowering physician in international practices for advanced diabetes care. Lifetime Achievement Award for contribution to Uttar Pradesh Diabetes Association. Ma'am has delivered several prestigious orations and established Diabetes Education Foundation program in Prayagraj. Areas of interest of ma'am is thyroid, diabetes education, and growth disorders. And publications, ma'am has around 260 publications in national, international journals and chapters in various books. And ma'am is editor-in-chief of several monographs and books.
Welcome, ma'am, and thanks for agreeing to be a part of the symposium.
Sorry again, I thought it was 4:30. I'm really sorry about that.
Not at all, ma'am, not at all. You're just in time. Thank you, ma'am.
I feel honored to welcome our next, our chairperson, Professor S.K. Singh, sir. Sir is former director of IMS, BHU, former dean, Faculty of Medicine, professor, Department of Endocrinology and Metabolism, IMS, BHU. And sir has done his DM Endocrinology in 1988 from IMS, BHU. And sir is professor, head Department of Endocrinology and Metabolism in IMS, BHU. He's former president, Vice President and Secretary ESI, President ESI 2017, Professor of Endocrinology since 2003, and sir has various INSA and European Commission fellowships, publications around 165, and 80 international and 86 national publication. Sir is also principal investigator of various ICMR and UGC projects. Welcome, sir, to the program.
Thank you, sir. And I would request Bajaj ma'am and Singh sir to please give us their overview of what do they think Ramadan and diabetes should be all about. Over to you, sir and ma'am, please.
Yeah, I think Dr. Bajaj would take over first because ladies first.
Yeah. So congratulations. I think the timing for the symposium is just perfect because I think the roses will be starting next month, right?
Yes, ma'am. 1 month, exactly 1 month, ma'am.
Exactly. So I think the timing is perfect. And of course, the major focus here is on Ramadan fasting, but I see that there's a very interesting topic on intermittent fasting as well, which really needs to be discussed because it is a lot in vogue these days.
Yes.
Amongst the fastings, I think Ramadan fasting is the one that is more studied, more looked into. And of course, congratulations. I think, Shaila, you're part of the DAR committee as well.
Yes.
I think those guidelines are also almost done.
Yes.
And you're part of that. So congratulations for that.
Thank
And I'm
you.
sure some of that is going to be discussed now as well. So I'm really looking forward to it.
Thank you, ma'am.
Of course, they're all like you can have Lent fast, you can have day once a week fast, you can have once a month long fast. So there are various fasts across the globe which are followed, and different religious sects follow them differently. Different religious sects have their own timings of opening their fast as well. So I'm really looking forward to the symposium, and especially in patients with diabetes. How does it impact their blood glucose values? How intensively you need to monitor? Can you monitor during the fast? How do you adjust the medication? I think this is a perfect timing for the symposium. And congratulations to Dr. Jabbar and the whole team who will be talking about it. And I think all the best. I think we'll go ahead.
Thank you. Thank you very much, ma'am. Thanks for those very kind words. Sir, if we could have your insights also.
First of all, thank you. Thank you, Dr. Shahala, for giving me this opportunity to make us part of this webinar. And I acknowledge Endocrine Society of India and Dr. Jabbar in particular for choosing this very important aspect, that is diabetes and fasting. In fact, we need to know a lot about fasting and diabetes. As Dr. Sarita has already mentioned, that intermittent fasting was one, but that is more exploratory than what we are going to talk about, is giving education to our patients, empowering them for fasting during religious fasting. So religious fasting is very, very important practice in the society. And I think very soon after a month, Ramadan will start, which is a longest religious fasting known. Is almost of 1 month, 29 days or 1 month, which is very large period, though we have smaller fasting days, intermittent fasting, like in various religion, but this is very relevant. And two important things are to be discussed. One is that what would be the impact of fasting on those who have diabetes, and particularly the type of diabetes and the type of treatment they are receiving for diabetes. And another important, that what would be their response and responsibility when they are fasting, during when they have diabetes and they are fasting. So they must know what to do and what not to do during this Ramadan period. I think we'll also have some information regarding, many times patients ask, should I go for fasting because Ramadan has come? And doctor, do you recommend for fasting or not? So before the doctor replies to it, I think doctor should also know what kind of fasting and where they have exemptions, where they can be exempted from fasting, though it is a very religious aspect, but we should know when we are transmitting this information to our patients. Yes, you can go for fasting if it is important, but you may not go for fasting, and there are exemptions to it. There are religious exemption to it. So I think the knowledge would definitely overcome most of the hurdles, and will also empower our patients to follow what they have been practicing in their life. And with the rise in the prevalence of diabetes, I think more and more patients are having this problem. And obviously, the religion has to go a long way. So we have to keep pace with the religion. That cannot be molded, or that's good for healthy society. So I think I acknowledge the attempt of the Endocrine Society for organizing this webinar. Thank you very much.
Now, before we go ahead, I believe it's Dr. Jabbar's birthday today.
Sorry?
You're mute. You are mute, Sheila.
I said, yes, ma'am, we are planning a virtual cake cutting at the end. We thought we'll
Oh,
surprise
happy
you.
birthday before the
Thank you.
cake is cut.
Yes,
So I'm
ma'am.
sure I get my share.
Ma'am,
Very, very happy birthday. Many happy returns, Dr. Jabbar.
happy
At
birthday.
least
Oh,
birthday,
oh, that I didn't know, Dr. Jabbar.
we can feast today, and of course you will have your fast next month.
Inshallah.
Very lucky. It's a lucky celebration. He is not spending single penny.
Thank you very much,
Celebrating
sir.
his birthday.
Ma'am, Sarida ma'am, Shailaji, Beatrice, Amit bhai, all my friends. Thank you again.
Taking this further, if I can
Happy
ask Dr. Siddharth to please start the proceedings and introduce Dr. Beatrice.
So let's start with the first topic of the presentation. So I am very honored to introduce the Beatrice and ma'am. And ma'am is a associate professor and head department of the endocrinology in Nizam Institute of Medical Science, Hyderabad. And ma'am has also received Anil R. Seth Award in 2021 from Endocrine Society of India. Ma'am is also a receiver of a gold medal in the DM endocrinology in West Bengal University of the Health Science. Ma'am has also received a gold medal in internal medicine from Association of Physicians of India, and she has also authorized various articles in various international and national journal, and she is also actively involved in several research projects. And she has also authorized the chapter titled Endocrine Disruptor Chemicals. So, and ma'am is also a scientific secretary in ESI 2023. So, so we can now start the first lecture. The topic is intermittent fasting and evidence. So, over to you, ma'am.
Thank you, Dr. Amal. Very good evening to all of you, and a warm welcome to this webinar, where we'll be discussing about fasting and diabetes. So firstly, let me thank the Endocrine Society of India for giving me this opportunity, especially Sheila ma'am. So what I'm going to be doing over the next few minutes is I'm going to be exploring about the scientific evidence available for intermittent fasting per se. So the specifics of religious fasting will be dealt with in later lectures. So when I talk about intermittent fasting, what do I mean by intermittent fasting? So intermittent fasting could be alternate day fasting, or it could be the 5:2 diet, or the time restricted eating. So the alternate day fasting is basically there is one fast day and an alternate feast day. So the fast day could be anything between a 0-calorie diet to up to 500 kilocalories in a day. The 5:2 diet is fast days for 2 days per week and feast days or ad libitum intake for 5 days per week. So the fast days will include about 500 to 1000 kilocalories in 2 days per week, which can be consecutive or non-consecutive. The time restricted eating, which is in vogue, and most of the religious fasts fit into this time restricted eating, where what happens is there is going to be an eating window, for example, about 8 hours, and there is a fasting window, for example, about 16 hours. So I'm going to be talking about the intermittent fasting, all these 3 forms of intermittent fasting in general. So intermittent fasting, it's the beneficial effects of intermittent fasting are seen irrespective of the weight loss. So there is some degree of weight loss, but we see the beneficial effects even, or probably we can tweeze out the effects or the beneficial effects of intermittent fasting from weight loss as well. So how does intermittent fasting work? So this is the concept of the metabolic switch. So what happens during periods of fasting is that the triglycerides are going to get broken down to fatty acids, which are used for energy. And the liver is going to convert these fatty acids to ketone bodies, which are going to be used as a major source of energy for many tissues, especially the brain. Now, at what time this switch happens, it depends on the duration of fasting. So anytime after 12 hours, this switch is flipped on. So this sort of intermittent fasting, where the body is going to turn on the metabolic switch, there is going to be, the body is going to be periodically switching between liver-derived glucose and adipose cell-derived ketones during the fasting periods. So this fasting is going to also stimulate evolutionarily conserved adaptive cellular responses. So this is going to improve the glucose regulation. This is going to increase the stress resistance, and it is going to suppress the inflammation. And there is upregulation of autophagy. Autophagy is nothing but the damaged molecules are removed and repaired. So all these pathways are in fact sort of untapped, especially in all of us, and especially in those people who are obese and or those who overeat and those who are sedentary. So these are all evolutionarily conserved pathways which are triggered or which are activated when somebody does intermittent fasting. And these ketone bodies are not only fuels for the body, but they're also messengers. So they're going to activate a whole lot of other molecules which are useful for the body. So there are a whole lot of molecules, but I'm just going to mention a few. FGF21, and there is going to be the BDNF, or the brain-derived neurotrophic factor signaling, which is help in synaptic plasticity and neurogenesis. So this is the basic premise how the intermittent fasting works. So this is the weight loss as well as the metabolic switch. So effects of intermittent fasting, now whatever scientific evidence we have, we're going to be looking at it this way. So we're going to look at the effects on body weight. We're going to look at the effects on body composition and the energy intake and the diet quality, the cardiometabolic factors, glycemic control, aging, and cognitive functions. So we'll talk about intermittent fasting and body weight. So this has been studied extensively. So what has been studied is the alternate day fasting and the 5:2 diet. So these are going to cause about 4 to 8% weight loss from baseline over a span of about 8 to 12 weeks. Now, one caveat or one drawback of the literature available so far is that we do not have very long-term studies. So most of these studies are for 3 months or 6 months, and there are a couple of studies for up to 1 year. So long-term studies are lacking in this aspect. So whatever short-term data we have, so this is what it shows. Time-restricted eating, on the other hand, causes lesser weight loss than the alternate day fasting and the 5:2 diet. So time-restricted eating causes about 3 to 4% weight loss from baseline over a span of 8 to 12 weeks. And 5:2 diet especially has been studied in type 1 and type 2 diabetes over a span of about 52 weeks. And they found that there was a 7% weight loss in these patients. So what has been shown in all of these studies is that intermittent fasting might benefit, especially those with obesity, overweight, insulin resistance, pre-diabetes, type 1 and type 2 diabetes. What about the body composition? So whenever we lose weight, it's going to be 75% of fat mass and 25% of lean mass. But what has been shown in certain studies is that time-restricted eating, when it is combined with resistance training, there is muscle mass maintenance or even accretion of muscle mass. And there is a significant visceral fat reduction in the 5:2 diet and the alternate day fast. What about the energy intake? There is a total decrease in energy in all these forms of intermittent fasting. There is about a 10 to 30% reduction in energy intake. So the question arises, what about the feast days? So do people who are undertaking an intermittent fast, do they tend to overeat during the feasting days? And what about the eating window in the time-restricted eating? Do they tend to overeat or really feast during that eating window? But the good news is that most of the studies have shown, even if they try to overeat, there is still a net energy deficit. So there is no full compensation for whatever lack of food is consumed on the fast day. So even if they overeat during the feast day. So there is a net energy deficit, and this leads to mild to moderate weight loss. What about intermittent fasting and diet quality? So whenever they fast, so is it going to be an intake, a higher intake of high carbs and high calorie food? So this again has been studied, and it showed that the proportions of dietary fat or carbohydrates or protein intake did not change from baseline. And even the levels of sugars or saturated fat, the MUFA or PUFA, cholesterol, sodium intake did not differ when somebody undertook an intermittent fast. Fiber consumption, on the other hand, did not change, and it was low even at baseline and even after undertaking an intermittent fast. Intake of beverages, again, there were no change. But what has not been studied so far is the micronutrients. So we do not have established studies on what happens to the micronutrients. Is there any deficiency of micronutrients in those people who undertake an intermittent fast? So clinicians should watch out for this, whether somebody who undertakes an intermittent fast could have micronutrient deficiency is not known. So hence we need to watch out. So intermittent fasting and cardiometabolic risk factors again has been studied, and it has been shown that there is a decrease of systolic blood pressure to the tune of 3 to 11% from baseline, and a decrease in the diastolic blood pressure in the tune of 3 to 13%. But in all of these three different types of intermittent fasting, there is no significant difference between the groups. And especially in those time-restricted eating, that is the early time-restricted eating, where the dinner or the last meal of the day was before 3 p.m., the BP reduction was there irrespective of the weight loss. And this is probably the salt intake is pushed a little earlier towards the day, and there is an increase in the salt excretion or natriuresis, which is again sort of propagated by the circadian rhythm. And there has been concerns about changes in the resting heart rate. And these studies showed that there is no significant changes in the resting heart rate, or there might be a mild decrease when there is some moderate weight loss. And the other aspects of the cardiometabolic risk factors, like the cholesterol. So there is a 10 to 22% reduction in LDL cholesterol, and there is a 16 to 36% reduction in triglycerides, which is expected because the triglycerides are going to be broken down into the free fatty acids, and that is going to be converted to ketones to be used as fuel. But there is no change, or there might be even a slight decrease in the HDL cholesterol. But what has not been studied, or what we need to understand when we look at these findings in these studies, is that we do not have data regarding when the sample was drawn. So was the sample for lipid profile drawn during the feasting or the fasting days? So we do not know. A prolonged fast again can increase the triglyceride level. So again, we do not know about that as well. Glycemic control, again, this is an area of interest. So the fasting insulin has been shown to be reduced by about 11 to 38% in those who undertook an intermittent fast. So the effect was more pronounced in those with baseline increased insulin levels. And many studies were done in those people who do not have diabetes. So the fasting level did not differ much, which is not surprising. And so there was no changes in the HbA1c as well in those with no diabetes. But in type 2 diabetes, the 5:2 diet reduced the HbA1c by about 0.5%. In type 1 diabetes, there is no change in the HbA1c. But what all of these studies have shown us is that fasting 2 days per week is safe in patients with type 1 and type 2 diabetes and associated with few hypoglycemic events. Again, this depends on what sort of medications the patient is on, and depends on the monitoring levels as well. Intermittent fasting and inflammation again has been studied, and there have been several trials, and the 7 trials showed no significant difference in the inflammatory markers. And there have been few smaller trials which have looked at it, and they have shown a non-significant decrease in the inflammatory markers. But what has been shown uniformly is that there are reductions in markers
Beatrice,
of...
your slides are not moving, dear. Beatrice, your slides are not moving, dear.
Okay.
We are stuck on the IF and cardiometabolic risk factors on the screen.
Okay, ma'am. Has somebody paused it, my screen sharing? Okay.
Bashir, can you have a look at it, please?
Yeah, it's okay. Are you able to see now, ma'am?
Yeah, I can see now. Thanks, Beatrice. I can see now.
Yeah. So I was talking about inflammation. So there is no significant difference in the inflammatory markers, but what all of these studies have shown is that there's definitely a reduction in the markers of oxidative stress. And this could be one of the mechanisms as to how there is an improvement in the insulin sensitivity in patients or in persons who undertake intermittent fast. So another area of interest is the non-alcoholic fatty liver disease. So there is an improvement in the NAFLD in those persons who undertake intermittent fasting. And this has been assessed by non-invasive tests. So time-restricted feeding, it significantly improves the non-invasive markers of fatty liver disease, like the FIB4 score, the NAFLD fibrosis score, and the BART score. And this has been studied especially during the period of Ramadan. And there have been 2 major trials or randomized control trials, which has looked at intermittent fasting and NAFLD, where they have looked at alternate day fasting versus controls and alternate day fasting versus time-restricted feeding. So in all of these, they have shown that alternate day fasting scores a little better when it comes to improvement in the non-invasive markers of fatty liver disease. And this is one disease where intermittent fasting works not only by weight loss, but also by weight loss independent mechanisms like the metabolic switch I was talking about. But what is the best method of intermittent fasting in NAFLD is still yet to be studied. And this again is something of interest because there have been intermittent fasting and cognition, because animal studies have shown that those mice or rodents who have been calorie deprived, they showed an improvement in spatial memory, associative memory, and working memory. And even a handful of clinical trials, in fact, they have shown that older adults had improved verbal memory when they were put on a short-term calorie restriction. And 2 years of daily calorie restriction, in fact, leads to a significant improvement in the working memory. So this, in fact, is a potential therapy which needs to be studied further in stopping brain aging, and its role in neurodegenerative diseases, again, has to be studied. So this is a gist of whatever I've told right now. So intermittent fasting, there is going to be a decrease in energy intake up to 10 to 30%. The diet quality, there is no change in the macronutrient intake. There is no change in the beverage intake, but we do not know much about the micronutrient intake. The body weight in alternate day fasting and 5:2 diet decreases by about 4 to 8%, slightly lesser in the time restricted eating, that's about 3 to 4%. The body composition, there's a decrease in the subcutaneous fat mass, there's a decrease in the lean mass, and there can be a decrease in the visceral fat mass. Inflammation, not much changes in the markers of inflammation, but there is definite reduction in the oxidative stress markers. And regarding cardiovascular risk, there is a decrease in the blood pressure, LDL cholesterol, and triglycerides. Glucoregulatory factors, there is not much change in the fasting glucose, but there is definitely a reduction in fasting insulin, insulin resistance, and also in the HbA1c. So what about the safety of intermittent fasting? There have been concerns about a few side effects which have not been proved much in the trials. So there is no increased incidence of constipation or diarrhea or nausea or dry mouth or halitosis or irritability or fatigue or dizziness. But what has been shown is headaches can happen in the first 2 weeks to 1 month, but this and there's also dehydration, and this could be taken care of by increasing the water intake. The other question that comes to our mind is there is going to be periods of fasting and feasting. So can intermittent fasting increase the risk of developing an eating disorder? But the good news is there's no increase in the rates of binge eating, purgative behavior, depression, or fear of becoming overweight when somebody undertakes an intermittent fasting. But this has not been studied in somebody who's already has an eating disorder or is prone to develop an eating disorder. So who can do intermittent fasting? Adolescents with severe obesity, adults with normal weight, overweight, or obesity, adults with hypertension and or dyslipidemia, patients with insulin resistance or prediabetes, and patients with type 1 and type 1 diabetes mellitus or type 2 diabetes mellitus, but with adequate monitoring. And who should not do intermittent fasting? Because this population has not been studied so well, so we do not know about the safety. Children under the age of 12 years, adolescents who are normal weight, women who are pregnant or lactating, individuals with a history of an eating disorder, and individuals with a BMI below 18.5 kilogram per meter square, and individuals over the age of 70 years. So there are some limitations to whatever scientific evidence I've just talked about. Most of these are small studies. The quality of some of the studies are not very good. And many of these studies are to limited geographical areas, mainly the US. And in this sort of study, bias do tend to happen because blinding is not possible in these kind of trials. But what needs to be studied further, because we do have encouraging results with intermittent fasting. Long-term clinical trials more than 1 year is a need. Health benefits of intermittent fasting in specific populations who may benefit from intermittent fasting, like those with type 1 diabetes, type 2 diabetes, PCOS, or thyroid disorders. And direct comparison of all these 3 forms of intermittent fasting and effects of weight loss versus fasting on the metabolic parameters again needs to be studied. A few take-home messages from whatever I've talked about now. So intermittent fasting, yes, it produces mild to moderate weight loss, about 3 to 8% loss from baseline over 8 to 12 weeks. But we do not know about the maintenance and management in long-term weight loss, because that needs to be studied further. And the impact on cardiometabolic factors again need to be studied. But what has been shown is that it is relatively safe with few adverse effects. And intermittent fasting, this is the bottom line. Intermittent fasting is effective in weight loss, but the effects in the prevention and management of metabolic disorders, that needs further study and further clarification. So I end by quoting Benjamin Franklin. So the best of all medicines is resting and fasting. Thank you all for patient listening.
Thanks for that, Beatrice. Thank you very, very much. I think that was very, very eloquent. And I would request Sir and Bajaj ma'am. Ma'am, there are a few questions. There are 2 or 3 questions in the chat box. Or I could possibly address them to Beatrice. Beatrice, one of the listeners wants to know, how long does the person have to follow intermittent fasting? And what happens when this fasting period is over? Is it well defined? Do we do it for 1 year, 2 years? What exactly, when you talk in terms of intermittent fasting, what are we actually telling our patients?
Okay, ma'am, how long does the person have to follow intermittent fastings? I'll talk about this Japanese village, the Okinawa population, which typically follows this intermittent fasting pattern. So they do it for life. And they have one of the highest or longest living population in the world with very less incidence of metabolic diseases. So my answer would be as long as possible. And what happens after the fasting is over? There have been studies showing that all of these beneficial effects that we have sort of accrued over the period of intermittent fast, it tends to get lost after some time. Okay. But there are also studies showing that certain forms of religious fast, they do have sustained effects, but again for a short period of time. So once you're off the fast, again, the metabolic switch is not there. So still the body goes back to using glucose as a fuel. So all of these cellular mechanisms which are protective, so they become dormant.
So it's like a lifestyle change, basically.
Exactly.
You're trying to tell us, right? And ma'am and sir, the second question which has come up is, of course, there's one question from me also, but intermittent fasting nowadays is propounded as, a way for diabetes remission and reversal. That's what everybody in the lay press talks about. I would want to know from Singh sir and Bajaj ma'am also, what is their final word on intermittent fasting being a way to diabetes remission? Beatrice, you said that is 5 to 8% of approximate weight loss, and it does translate into metabolic benefit. Would this persistently in the long term translate into some kind of diabetes remission or resolution, Beatrice?
Ma'am, we do not have long-term studies. That's what I was talking about. So we do not have any long-term studies. So only there are a couple of studies just over 1 year. So we do not know how useful intermittent fasting is to sustain the weight loss or cause more weight loss, and what it does to diabetes in the long run. That has not yet been studied.
Singh sir, Bajaj ma'am, your final words on intermittent fasting, please. I think by mistake they've logged off. No, Singh sir, Bajaj ma'am. Okay, till sir and ma'am get back to us, we will take this symposium further. And I would request Amal and Dr. Siddharth to please introduce Kalra sir, though we all know Kalra sir doesn't require. Ma'am, before we go to Kalra sir's lecture, I wanted to know your final take-home message regarding intermittent fasting. What do you think, ma'am?
Yeah, I'm sorry. Actually, yeah, the laptop was not displaying truant. I think I'm audible, visible, everything is good, right?
Yes, ma'am.
Yeah, Beatrice, I really enjoyed your presentation. And I'm so happy that you spoke about that Okinawa, that Japanese population,
yes,
which has the longest, I think, survivors, or they live beyond almost till 100. A lot of them are living. So, and I'm glad you clarified the fact that it can be carried on for life. It's a way of life, actually. Once you save. But what I was curious when you said about those 2 days in which they've had studies to show that type 1 and type 2 can follow it at least 2 days a week without any significant hypoglycemia. right? I think that's what you said.
Yes, ma'am. There should be
Yeah.
reduction in the
So-
insulin dosages.
So yeah, those adjustments would have to be made. But in the diabetes population, you cannot do it on a 7-day basis, right? You are saying it can only be done on 2 days, if at all, and then you would have to make all those adjustments. And if patients, at least who are not on any OAD, who are on lifestyle, for I think that would be the ideal population, or those who are obese, those who are hypertensive, those who are dyslipidemic, they would benefit maximally from intermittent fasting. And of course, the age cutoff and the other associated comorbidities, which would discourage intermittent fasting. So amongst all the different types of fasting, I think this is the one, because ketogenic also, if you cannot be followed beyond a couple of months, is the only one that you can continue, which has shown the maximum benefit. Thank you. Thank you.
Thank you, ma'am. Thank you. Over to you, Amal and Siddharth, please, to take this forward.
So coming to the second presentation, sir knows, everybody knows Sanjay Galia, sir. So sir doesn't need any introduction. He is a consultant in Bharti Hospital in Karnal. He is also past president in Endocrine Society of India, CEFIS, and he is also past president in Indian Professional Association for Transgender Health. And sir is also chairperson in Education Working Group, International Society of Endocrinology. So over to you, sir.
Sir's presentation has been sent to us, and sir will be joining for the discussion because sir is at this point of time traveling. Bashir, please, can you play sir's presentation?
Good afternoon, friends. We are approaching Ramzan time, and this is a time when we think about religious fasting. But then a question will come, what is the difference? What are the similarities between religious fasting and intermittent fasting? Now, what is fasting? Fasting is a willful abstinence from fluid, that's liquids, or solid, that is food, for a particular period of time. Some people will fast for religious purposes, that's religious fasting. Others may fast just for discipline or maybe to improve their health. So the motivation for fasting is always different. Intermittent fasting is in vogue these days, and there are different types of intermittent fasting. Some people will fast for a particular number of hours in a day. So you might have 12:12 fasting. That means 12 hours of fasting, 12 hours of window for eating. Others will be more severe with themselves, and they might have an 8-hour eating window or maybe a 6-hour eating window, and then the rest of the time, 16 or 18 hours, is the fasting period. This is hours per day. There are others who will keep a fast, intermittent fast, every day or every 2 weeks of the day. So maybe 2/5 fast would mean 2 days of fasting, 5 days of normal eating. 1/2 fast would mean that you fast on one day and eat the next day. So this is days per week. It can be 1/7 also. And these are also different types of intermittent fasting. Religious fasting is similar in some ways. So for example, people may keep a Sarka Septan fast. Sarka Septan means you fast every Monday or every Thursday or every Friday, once in a week. This can be a religious fast. There can be a religious motivation to it. Others will have a Sarka tidal fast. That means once every 14 days. So when the tides come. So you might have a fast on every full moon day, for example, or every full moon and every new moon. And yet another type of fast is once a month. This is called Sarka lunar, with the moon, Sarka lunar fasting. Religious fast depends upon where you are in the world, what religion you follow. Some people may abstain totally from food and drink. Others may abstain only from food, and yet they may drink fluid. And then there are others who may abstain only from certain types of food, like non-vegetarian food, for example. But speaking from the Ramzan point of view, the Ramadan point of view, Ramadan is a religious fast where you have to fast during the holy month from dawn till dusk. This is an obligatory fast for all devout Muslim believers. This is a mandatory fast, actually. And then there are certain fasts which can be done, per choice. Like you can fast every Monday and Thursday of the week, or either a Monday or a Thursday. There is also a fast where you can fast for 6 days during the month of Shawwal, following Ramzan. Other holy days, like during Muharram and otherwise also, these are times when obligatory or fasting may be done. These are known as Sunnah fasts. Sorry, not obligatory, but they are done by choice. That's a Sunnah fast. Now, we've seen that there is a lot of overlap between religious and intermittent fasting when it comes to the type of fasting. What are the differences now? First of all, the difference is in who keeps the fast and why they keep the fast. So, religious fasting is mandated by religion, and devout believers will keep the fast. That is one reason, one difference. The other difference is that if it's a religious fast, you will follow religious dictum. So, for example, the holy month of Ramadan, which follows the lunar calendar, you will keep the fast when the month comes. It can be in the depths of winter, it can be in the heights of summer, but you have to keep it. Why do we keep it? That's another difference, the motivation. So, with an intermittent fast, the motivation is usually health, physical health. But with the religious fast, the motivation is above that, not only physical health, but also spiritual, mental, emotional, social health. So when you keep a fast with a particular motive, you tend to achieve that motive. And this difference you see between religious fasting and IF. In religious fasting, people will get better physical health, of course, but they will also get better social bonding, emotional well-being, and a sense of spiritual well-being. These are the big differences. And then you see that this actually translates into better outcomes as well for them. The physiological impact of fasting will be the same in intermittent fasting and religious fasting. For example, lipid levels usually come down in most people. Weight will go down provided that you don't feast, you don't cheat. Blood pressure, glucose levels will also come down. This is in healthy people. Even in people who have, let's say, stable diabetes or maybe stable hypertension, the dose requirement of glucose-lowering drugs or antihypertensive drugs comes down. There are downsides as well. In intermittent fasting, the motivation is usually weight loss or physical health. Of course, people on intermittent fasting do follow cheat days, but if these are kept within limit, then the chance of weight gain, hyperlipidemia are minimal. Religious fasting, on the other hand, is usually followed by feasting, whether it is iftar at the end of the fast every day, or whether it is Eid at the end of the month of Ramzan. Now, feasting sometimes negates the benefits of fasting. And we have to be careful about this. We have to be able to motivate our community and people who are fasting to be able to feast within moderation. So we can teach them physio-friendly and also cook-friendly recipes, gut-friendly, cook-friendly, and calorie-friendly recipes, which allow them to feast as well, which allow them to get the flavor of the month, but also keep their caloric intake within limits. So like we said, the one big difference is spirituality. The motivation for religious fast is spirituality. The outcome is better spiritual health, better social health. The downside is that because of the feasting, we might end up negating these benefits. So we have to remind people who are doing intermittent fasting, let's say for health reasons, why they are doing it. They are doing it for the health of their body, not to trouble themselves. Similarly, in religious fasting, we have to keep reminding our patients that they are fasting to become better human beings, not to feast at the end of the fast. That is not the aim of the fast. The aim is to become better human beings, both physically, mentally, emotionally, and socially. So taking a balanced viewpoint now, we understand that there are different types of intermittent fasts. There are different types of religious fasts. Within Islam, we have Ramadan, which is an obligatory fast, and then we have Sunnah fasting, which can be done by choice. Depending upon the motivation, the religiosity of a particular person, we will get outcomes. So many times we have to balance biophysical health with religiosity. There are scales for religiosity and spirituality which are used. There is a difference, between being religious and being spiritual. You can be both of them at the same time. In Hindi, the words would be dharmik for being religious, dharmikta for religiosity, and being adhyatmik, that is being spiritual, or adhyatmikta. Both overlap, but they're not the same thing. So later on, we might want to talk about research, how we can add the concept of religiosity to the concept of risk stratification that we'll be speaking about today. When you want to stratify the risk for a particular person with diabetes for keeping Ramzan, you should be able to factor in how religious that person is. So first we've spoken about motivation as being a big difference. And then secondly, we've spoken about the concept of feasting after fasting. That is a big difference between IF and religious fasting. And we should be aware of that. We should be able to counsel our patients in a very person-friendly but proactive manner. With this introduction, I also look forward now to hearing the list of the ESI symposium on Ramadan and diabetes. It's great being with you. It gives me a sense of fulfillment, a sense of meaningfulness to be part of the ESI family and to be be able to take care of all of our citizens who are keeping the Ramzan fast. Thank you and Jai Hind.
Thank you, sir, for as usual, very lucid and so many innovative kind of ideas from you. So there are a few questions which I think you and chairpersons can answer. So one of the questions is that how to optimize the benefit of religious fasting in patients with diabetes and obesity. Sir is there, or Bajaj ma'am,
I
or
don't think he's there right now.
Yeah, I think he got logged off by mistake, maybe because he's traveling.
Yeah, I think you said he'll join for the discussion, but I don't think that will be possible. So I think, Hamid, that's a very valid question. We are not talking of the religious aspect here. We're talking of patients' well-being at the moment, right?
Yes, ma'am.
As to how to derive the maximum benefit. So I think a patient consultation, patients who are on the same medication and that has not changed over several years, they may not require that visit, but ideally, one visit to the doctor prior to starting the fast, prior to starting the Ramadan is a must. And then they have those medicines sorted out, how to monitor, how to continue their medical, what is the timing of the medications, which ones are safe, which ones need to be discontinued. I think that is of the topmost priority during that month-long fast. I think that was your question.
Yes, ma'am. Yes, ma'am.
Yeah.
And one, yeah. So basically, the thing is that we need to have some kind of follow plan also, because whatever the patient lipid parameters and improvement in weight and improvement in body weight parameters which has been achieved during Ramzan. So if that can be sustained, then it will be a very big boon for the patients. So very good kind of counseling, as you have rightly pointed out, ma'am, during the pre-Ramzan as well as post-Ramzan counseling is also very.
But Hamid, if I'm not wrong, because of the feasting, perhaps some people do tend to put on weight. So I think.
Yes, ma'am, definitely.
So we
yeah.
have to be very wary. So of course,
Yeah.
the pre and the post, the post may
Yeah,
be
yeah.
more important than the pre in
Yeah,
that respect, because it will be counterproductive as far as the blood glucose values are concerned.
yes, ma'am.
Yeah.
And Carla sir rightly pointed out, because fasting in religious circumstances, it is also associated with feasting, not only at the end of the month of Ramzan, but also daily at the time of iftar. So we need to take care of that also, as sir has pointed out, that we need to have gut friendly and health friendly and all kind of friendly kind of recipes should be there, innovative kind of recipes. And there were many innovative kind of recipes there in woman corn, ma'am. So we can replicate these things.
Thank
Yeah,
you. Thank you.
yeah, yeah.
Actually, the
So
other
we can,
thing is the very high fat content
yes, ma'am.
of the meals both times, right? Iftar and suhoor also. Both the times it's very high content. I suppose it's satiating and keeps the energy going for longer. Even of course you're not eating during that time. So I'm sure there has to be scientific apart from the religious connotation there. But that really desperately adds to the calories. And when you break the fast, it's invariably with dates, if I'm not wrong. So patients, otherwise also patient will ask, may I have dates or not? But what about the dates that are taken at the time? I mean, they're really packed in sugar. They're not the calories, but the sugar content would be really high.
Ma'am, but a single date is allowed. If you have a single
one single, of course, I would
amount
allow.
of calories which are there. The problem is not in the date, ma'am. The problem is the quantity of dates.
That's exactly, Shaila. I don't know how you said one date. I'm sure impossible to have just one date. It's like saying one kaju khalo. One kaju is no, sorry. You have to have
totally agree with
bunch.
you, ma'am. So we learned the hard way that when we said it was okay to have dates, we have now started asking the question, how many dates are you consuming? Because actually 1 or 2 dates, ma'am, are not a problem from the calorie content also, because they have additional minerals, fiber, etc. But the problem happens with, as you said, ma'am, with the feasting, with the overconsumption of everything which happens in the end of the day. And this overconsumption, especially, ma'am, in some communities starts at iftar and practically ends the next day morning. So we do have certain issues, a lot of more education, which I think Umesh is going to talk about. Because in the interest of time, Umesh is going to talk about what lessons we've learned, where we were, and where we are, because we have come a long way. I mean, there's a lot of stuff.
As far as the date story is concerned, half the time, 50% of the answer is not heard. So once you say yes, you can have it, then the mind closes the ears, shut out. I never heard how many you said. You said you can have it. So, I mean, you have to be very wary of those sort of tricky answers later.
Yes,
so it was very dogmatic.
Totally agree.
You can have two, like two, not yes. There should be no yes, no. You can have only 2 dates, no more. I mean, very clear cut, not a yes, no situation.
Very true, man. Totally agree.
Very true, ma'am. Yeah.
Amal, you can introduce Dr. Umesh.
I think the whole Women Con team is back here.
Yes,
yes, ma'am.
This is
Definitely.
the second edition of Women Con.
Very
yeah.
true.
In virtual mode, ma'am.
Yes, very true.
Yeah.
Thank you so much, Kalra sir, Bajaj ma'am, for your inputs. Now I'd like to call upon Umesh Garg sir. Sir is consultant endocrinologist and head of endocrinology department, Pushpanjali Hospital, Agra. And sir has more than around 15 publication in index journals, and he's a regular speaker as well as faculty at various forums. Over to you, sir.
Well, good afternoon, ma'am. Good afternoon, Hamis sir. It's always a blessing to talk after eminent speakers like Beatrice and Sanjay Kalra sir. And that's to a question of Dr. Saptarshi. He will talk about after me. So my work is almost very simple now. I will share my slides. Okay. So I am going. My slides are visible, ma'am?
Now, yes.
Yes.
Yeah. Okay. So next 20 minutes or so.
Slideshow.
Yeah. So next 20 minutes or so.
Slideshow.
Next 20 minutes or so, I will talk about, we have gone to intermittent fasting, to religious fasting, and what happens to us. we are as a clinician are facing our patient with diabetes who comes to us. So what they should be taught, educated, how they can safely we can manage them. So these are disclosure, none to disclose. So this will be my overview. We will go for diabetes education. What are the scientific evidence and what are ways to go? So diabetes education in pre-Ramadan. Why it is important? Because as per EPIDIAR studies which were given in study, almost 3/4 of type 2 diabetes and 42% of type 1 diabetes have a fasting for more than 15 days during the period of Ramadan. And it is very important because even in the EPIDIAR, it was only 74%, but in CREED studies, it reaches up to 94%. That is almost all patients, because what happens whenever you are coming with these safer drugs, almost all type 2 diabetic subjects will go to fasting. And it is very important because it's not only 15 days, many of them will go for almost daily fasting. So why it is important? We are going to have a holy month of Ramadan this year from 11th of March. In India, you will have a almost fasting period of 15 hours plus minus 1 hour. And what is the optimal time? It is often said that the optimal time for pre-Ramadan education is 6 to 8 weeks prior to holy month of Ramadan. So we are already almost 4 weeks prior to. So this is the right time to talk about what actually happens. This figure was taken from Canadian Family Physicians editorial, where they talk about what should be the education. Almost across the globe, depending 12 to 8 hours goes from the Sahar to Iftar, goes in fasting. Thereafter, there is a prayer and feast, which we are talking about. Then maybe sleep or may not be, and in the period of Sahur or what we call Sari. So for these patients of type 2 diabetes who has to go in India for a period of 14 to 16 hours of fasting this year, what we need to do is we have to assess the initial assessment and focused education and motivate them, what we are calling about religious motivation. And the management plan should be patient-centered and individual, because no two type 2 diabetes or even any subjects are same. So what are the targets? Who should be involved in the pre-Ramadan diabetes education? All of the stakeholders. It is not that the only patient should be the part. All of the healthcare professionals, our team should be the involved. So is the individuals with the diabetes and their family member. But this is not the whole story. All of the general publics, particularly leaders in the community and religious leaders, including muftis and imams, should be included, because their impact is much more beyond a simple teaching. They are trusted upon, and there is also a what we call spiritual aspect of that also. So for pre-Ramadan assessment, IDF has given a lucid and very good flow how to proceed them. Almost we should assess each diabetic patient 6 to 8 weeks. This is the return time to look for their detailed medical history, whether they can manage self-management, their ability, whether they are having any comorbidity, and what is their previous experience in managing the diabetes and fasting, and is there any other aspect which can increase the risk of fasting. So we have to risk stratification, and we have to talk about self-monitoring of blood glucose. We have to tell when to take the break the fast, when to do the exercise, and how can we plan food and meals. We were talking about that the iftar meal should be something which is so and friendly, caloric and gastronomic and all these, and how we can adjust the medication during the fasting. These should be the done in the pre-Ramadan assessment phase. So the component is risk, as we already did, what should be the advices, and how to identify the hypoglycemia as well as hyperglycemia, which can happen after the feast. So if we talk about when we assess the risk, low to medium risk, depending upon their factor, they can be allowed easily, while high risk, even type 1 diabetes is a high risk group, but we know that almost 40 to 60% of type 1 diabetes also fast for more than 15 days, though the appropriate regime may not be well known. So we have to talk about, most importantly, to risk stratification, we have to tell the patient about self-monitoring of the blood glucose. We should tell the patient that Islam allowed the pricking of finger to match the blood glucose level. When to test, how to test, these are important depending upon his or her conditions. Ideally, they should do it before the morning meal, that is prior to suhoor, then in the morning, midday, particularly prior to iftar and 2 hours after the iftar. Apart from this, whenever he or she is having any symptoms such as hypoglycemia or hyperglycemia or feeling unwell, he or she should go for a self-monitoring of blood glucose. What should be the dietary advice we were talking about, as Dr. Hamid Ashraf and Sanjay Kalra sir were discussing? The meal should be well balanced, though we know that we are discussing that it contains high fat due to satiety value and providing the depot of energy. So 40 to 50% complex carb, not the simple carb. So the spike should be less, rebound hypoglycemia should be less, and there will be a long duration of action, and 20 to 30% of fat, 20 to 30% of protein, and fat should be minimized to an extent where to counteract the free fatty acid rise, but to take a sufficient amount. So 30 to 35% of fat, particularly with mono and unsaturated mixed fat, will be there. And all of the carb should be low glycemic, high fiber foods, and there should be fruits, vegetables, salads. Those who have a saturated fat total can be 30 to 35%, but that should be mono or polyunsaturated, that is the healthy fat. While unsaturated fat should be avoided, we should minimize the jaggery, and we can take the oils, as a member discussing and sir were discussing in the women con. We have a lot of dietary patterns to discuss. So we also need to tell the patient when to break the fast. We have to break the fast if there is a documented hypoglycemia or hyperglycemia that is less than 70 or more than 300, or if no documentation but symptoms of hypoglycemia or hyperglycemia or acute illness occurs. These are the symptoms everybody know, but we have to reiterate again and again, because as ma'am said, once we say you can do fast, he will not hear you further. So that has to be reiterated during the initial 6 to 8 weeks, every week. That can be done in either a group or individual sessions. So what are the positive impact? Sir was asking. So there has been beneficial effects of education on nutrition. There has been evidence I will talk about. If we educate regarding the nutrition, meal intake, and dose adjustment, healthy lifestyle, they tend to have a safer and healthy manner. And now we are having the technology which manages the diabetes and predict hypoglycemia and keep a good glycemic control. So there are studies which has shown the clear benefit of this focused pre-Ramadan diabetes education on glycemic control, as well as weight loss, as well as reducing the risk of hypoglycemia, minimizing the glycemic variability and lipid profile also. So if we look pre-Ramadan education impact, it is not only during the period of Ramadan, they can be long last even beyond Ramadan if feasting is minimized. So as we know, what are the important aspects? There is a greater of education is greater glycemic control, better self-monitoring and awareness, sustained motivation to adhere to the guidance, and this give a greater empowerment to do fast during the month of Ramadan. So now the evidence is that we can use pre-Ramadan education to achieve safe fasting during Ramadan, and it allows us to have a better understanding for requirement for educational programs. So what are the evidence I will talk about? One of the very famous program was Ramadan Education and Awareness in Diabetes program in UK, which has a multiple session in Arabic as well as Urdu and Somali and English, 2 hours every 2 to 4 weeks prior to Ramadan, consisting 4 episodes that include dietitian, diabetes specialist, nurse, practitioner, and community health worker along with the patient. They give you Ramadan focused meal planning advice, exercise and medical assessment regarding glucose monitoring and how to recognize and identify the complication. And the outcome of this READ study was that there was a loss of 0.7 kg weight in the subjects who have received the pre-Ramadan education compared to those who have not received the education. The absolute weight difference was 1.3 kg, and this was independent of the drug used. There was significant decrease in the hypoglycemic episodes in the subjects who have received pre-Ramadan education. So weight reduction is there, hypoglycemia reduction is there, and even after long term, glycated hemoglobin, just like in glycemic uh, legacy effect of DCCT and trials, UKPDS trial, the even HbA1c reduction was maintained to a lesser extent even after 1 year. So they were of opinion that it focused education can, during our pre-Ramadan period, can empower the patient with diabetes to manage their diabetes efficiently, minimize the risk of hypoglycemia, reduce the weight gain, even can cause a insignificant weight loss, and then thus we can have a multiple metabolic benefits. This was another study from the Egypt, which was published 5 years back, which was a prospective interventional control design on 320 subjects with type 2 diabetes, and 120 received the intervention in 3 phases. It was a pre-Ramadan as well as Ramadan, and post-Ramadan was intervention was there, and we look what was the hypoglycemic risk and what was the biochemical parameters. HbA1c, fasting plasma glucose, both were reduced in all group, but due to impact of fasting. But hypoglycemia was reduced by significantly 15% in those who have received pre-Ramadan diabetes education, and it remained statically low HbA1c in those who have received the education. Not only HbA1c and hypoglycemia, but LDL cholesterol was also reduced, as Dr. Beatrice said. LDL as well as triglyceride is reduced with fasting, but when keeping the same fasting, education leads to more reduction in LDL reduction than those who have not received the education. So these were the outcomes. What was the impact in body weight as well as the obesity, BMI, and systolic blood pressure, as well as LDL? There was, though fasting usually doesn't carry a significant impact on HDL, but in this study, there was a slight improvement in HDL also. There was another studies which was published almost 8 years back, when they look for what are the glycemic improvement, hypoglycemic risk, and metabolic control on diabetes education. Similarly, there are a lot of studies. One was from Turkey a few years back, that pre-Ramadan education lead to reduced HbA1c, reduced hypoglycemia, not only during the phase of intervention during the Ramadan, but it maintained after the period of Ramadan also. Because one of the most important aspect is not just avoiding the hypoglycemia, but to appropriately take the meal during the iftar. So hence, keeping the glycemic control and metabolic control very well. In same education, we can see this is a graphical representation of that. This was one of the recent 3 year back program. There was a meta-analysis whether of all available studies, whether they can find anything which is the importance of pre-Ramadan education in diabetes. Answer is yes. This is forest graph which shows that pre-Ramadan education was associated with HbA1c reduction in almost all studies with a mean significant difference of 0.46%. As well as not only HbA1c, LDL was also reduced significantly in all studies. So was the body weight also. So we have evidence that it reduces hypoglycemia, it improves HbA1c, it gives metabolic benefit. Is there any lacuna? Answer, yet what are ways to go? If we look, there are different guidelines, different preaching across the globe. There is no unanimity, hence the results are varying, and we need to take a homogeneous depending upon their variations. So these are the issues. And one is how many people are using these guidelines. In India, as we can see, the ratio of physicians in a tertiary center is around 70%, but it is quite low at primary care level. So we need a further research in high risk group, particularly in comorbid conditions, how we can modify, because it is not only glycemia, but other parameters also. We need to look for how to optimize the education program for adolescents and children with type 1 diabetes. Yes, they carry, and now we have evidence that the glargine is safe. We can manage the twice daily, but despite knowing the fact that basal bolus is the gold standard, but that is not practical. And we need, because the era is coming of webinar and patient is having a telephonic and consultation, how we can improve our online education content and what are their benefits. Now, as we know, in the all older studies, majority were sulfonylurea and all these, which have a more risk of hypoglycemia. But we do have a now newer armamentarium, our diabetes management with SGLT2, GLP. So almost majority patient, the spectrum is increasing, which are covered with these drugs. So with low risk of hypoglycemia, what is the current status? We need to know that with these drugs, what is the benefits of pre-Ramadan education on hypoglycemia. On the other hand, these drugs have a different consideration of safety profile because they may reduce intake, particularly GLP-1, or may cause dehydration like SGLT2. So we need to explore the risk and benefits in newer drugs era. And as we know, with the fasting, there will be not hypoglycemia, or hypoglycemia may be in the lower part. With the feasting, there is a hyperglycemia. We can minimize, but we need to reduce the glycemic variability, increase the time in range. And the most important is, unfortunately, it has been healthcare personnel and doctors. And on the other side is patient. But we need to include all stakeholders, be it our team, nursing staff, community leaders, religious leaders. They all need to be involved in this education. And we have to look whether is there any additional benefit of education to other stakeholder apart from patient and doctor, whether they can provide additional benefit. We have to look. So in conclusion, yes, we know uncomplicated diabetic subjects can go to fasting safely. Yes, there are high risk group where they are going. Pre-Ramadan education reduce the risk in these group, and motivation is very helpful in reducing the complication of fasting, particularly hypoglycemia as well as hyperglycemia. And this focused education is the cornerstone of safe fasting. Thank you.
Thank you, Dr. Umesh, for such a elaborate presentation. I think you have covered all the things. And there are a few questions like what should be the optimal time when we should start these kind of counseling in our clinics?
Ideally, it should be it has been said that you should start counseling initially at first visit, but if you are focusing particularly pre-Ramadan education, then it should be 6 to 8 weeks. But if a subject with diabetes comes to you and he has a religious faith, in his time life, he will anytime will ask you. So you can prime at first visit to you, but to a focused program, 4 to 8 weeks, 6 to 8 weeks. And we are now only 4 weeks away from the Ramzan month. So it is appropriate time to start. If not started, we are not late. But those who have started, they have done well. So 6 to 8 weeks. But believe me, we should prime and educate even not only for routine education, but for future possible fasting for those who have a stakes. Suppose somebody from particular faith come to me, he wants to fast. We should start from the day one, because what happens once you say day one you can do fasting, he will not listen to you. So you have to prime each every visit from the day one. For focus program, 6 to 8 weeks is said.
Umesh, if I can add something, Hamid over here, ma'am, with your permission. I totally agree with Umesh, because what the latest data of DAR, we are just looking at the data from the DAR 2022-23 data which has been collected, and what was seen was that patients who monitored themselves during Ramadan were the patients who were actually doing monitoring during the rest of the year also. So a very, very important point I think Umesh has brought up over here is that you cannot actually, educate somebody just for a short period, just before a particular period of time, even though it's a religious fast. It's very important that every point of contact you reiterate that this has to be done, because the least incidence of hypoglycemia and the most monitoring was done by patients who were already monitoring throughout the rest of the year, because for them it was something that they just continued doing during Ramadan. The SMBG data that we saw, because though we are, when you look at the 7-point SMBG, which is advocated during the Ramadan period, but when you actually look at that kind of monitoring, it's not even being done by the type 1 diabetic patients. That's a kind of disconnect which is actually there. So when we further looked at the data, which is in the process of getting published, what was seen is what makes a difference is education to every point of contact. And I think that's where we will be able to make a difference, not only for this period, but throughout the year as far as complications are concerned. I just wanted to again reiterate what Umesh was saying. I totally agree with you.
Agreed, Sheila. The other thing is, Umesh, see, if your patient is on follow-up with you for a long time, and the patient comes to you 3 months and tells you, well, what do I do? Do I do the same thing like I did last year? So I think every visit is important. Like you said, day one, yes, important. But then you will have to vary that timing depending on the duration of follow-up that the patient has had with you as well. And monitoring is very difficult, very difficult. I think only pregnancy is possibly the, that one time when they really monitor. Before, after, it's all gone. Like, if you're not doing it, you're not going to do it during Ramadan either. So I think that take-home thing is very relevant. Yeah, thank you.
Singh sir, Dr. S.K. Singh sir, if we could have some comments from you, sir, please. I think we'll request Singh sir for the next session. If we can take this, Hamid, can we take this further?
Just a comment and just a brief opinion from ma'am also, because many times patients, they are reluctant to ask. So we should have some kind of proactive approach about fasting, because somehow I feel the patient, they are hesitant, they are reluctant to ask. So if some kind of this season is approaching, like Navaratri fasting is there or Ramzan fasting is there, then we should be proactive in asking our patient that if you are planning to keep fast, then definitely I'm here to help you. And if you have any kind of thing, so ma'am, your opinion about this, ma'am?
You're asking me, I'm sure, right?
Yes, ma'am.
Yeah, absolutely agreed there. And I think that's most important. That you have to be aware of it. You have to be aware of the fasts that are coming, irrespective of whether the patient asks you or not. So those 1 day fasts, okay, even they are very important in their own regards, because they won't have water through for almost from dawn to dusk, let's say, even if it's a 1 day fast. But otherwise, you need to be aware of those 9 day fasts, like we're saying Navratri, and very, very sincerely ask the patient, do you keep that fast, and then inform them appropriately.
Thank you, ma'am.
Thanks for that, ma'am. Thanks, Umesh. Thanks for that fantastic session. And back to the two kids. Amal, if to introduce the next speaker for the day.
So coming to the next presentation is from Saptarshi Bhattacharya, sir. The sir is senior consultant in Indraprastha Apollo Hospital, and sir is also a director in EDEC Noida, and sir is also ex-president of SPEED, and sir is also founder secretary to the Endocrine Society of Delhi, and sir has more than 90 publication in national and various international journals. So over to you, sir. Over to you, sir.
Thank you. And so if I could share my slides. Yeah. Thank you. So, very, very good evening to all of you. I think, just a minute. So I think most of the Dr. Kalra and has already set the tone for what we need to do and why we were doing the fasting, and Dr. Umesh just has built up on that. So what we understand from the current from whatever has been discussed is that so diabetes, it's a huge spectrum. So it's not that, or so somebody, you cannot have a blanket rule for all diabetes, and when it's applicable for diabetes management at any stage of life. So you need to look into what are the risks, what medicines to be given, and when we are extending it to the fast during Ramadan, we also need to understand that they can be actually systematically stratified depending on some criteria. So over the next 15 minutes or so, what I will try to explain is what are the risks associated with Ramadan fasting, and whether we can have a risk calculator for that, how actually in real life we can extend it to medical decision making, and finally we'll have the conclusion. So when we are talking about Ramadan and fasting, obviously the religious motivation plays a major role. So it's about self. What Dr. Kalra told was that it goes just beyond fasting. It's about improving yourself, and I think that concept for improving yourself can also extend to our health. So we also need to make them understand that this is an opportunity to improve your health also. So, but what actually happens is that there are some people with diabetes who will be quite okay if they're fasting. So somebody is a very well controlled diabetes and maybe receiving only metformin or a metformin gliptin combination. We all know that these medicines don't cause hypoglycemia, and if their HbA1c is well controlled, they might tolerate the fast very, very well. But on the other hand, there are some high risk patients who might have problems. So there are almost what we have from various studies is that 70% of high risk patients actually can actually go on to fast during the month of Ramadan. And again, in spite of that, many of them actually can fast without any problem. But we need to understand what are the risks associated with Ramadan fasting if we are looking into diabetes. So hypoglycemia is definitely a risk, as we all know. Hyperglycemia can also be a risk. One of the risks is dehydration, and associated with dehydration will be thrombosis and diabetic ketoacidosis. So, in especially in somebody with type 1 diabetes, so we need to look into these aspects and try to understand that if somebody is very predisposed to all these risks, maybe we need to take a call about whether the person should go ahead with fasting or not. So if we look into the earlier guidance for Ramadan risk stratification, so there are some people with diabetes who have very high risk, like severe hypoglycemia in the last few months, history of recurrent hypoglycemia, sustained poor glycemic control, type 1 diabetes, had a history of diabetic ketoacidosis, recent acute illness, pregnancy, chronic dialysis. So these are people who have actually very high risk. There are some high risk groups like who had moderate hyperglycemia, renal insufficiency, advanced microvascular complications, living alone and treated with insulin or sulfonylureas. There are, as we discussed initially, there will be moderate risk or low risk people who have, if somebody is on metformin or say acarbose or a GLP-1 analog or a gliptin or a thiazolidinediones, which does not cause hypoglycemia. If somebody is not on an insulin secretagogue or on insulin, the risk of hypoglycemia is actually low, and we know that the risk associated with Ramadan fasting will be less in those particular group of individuals. So it's a broad way. There are multiple risk factors. So obviously for it, so again it extends to all aspects of diabetes, and again can be if we are considering the fasting for Ramadan month, so all these parameters actually will play a role, starting from age, gender, duration and whether type and duration of disease, treatment, level of control, vascular complication. Hypoglycemia is a major risk because a person will be fasting for a quite a long duration, 14 to 16 hours. Comorbidities, exercise patterns, motivation, sleep pattern, and also the social resource, financial resource, and support. So all these do play a role in categorizing the person, and many of these factors were actually not considered in risk stratification guidelines. So we have this recently published, which was published around 2-3 years back, the IDF DAR risk calculator. So it looks into the risk of fasting associated with Ramadan very meticulously. If so, we assign points for type of diabetes. So type 1 diabetes gets a point of 1. Hypoglycemia again, so if somebody is having hypoglycemia unawareness, then that is obviously a major cause of concern, because this person can go into neuroglycopenic symptoms straight away, can land up in a coma. So that is given a very high score of 5. So glycemic control again is very important. So the score can vary from 2 to 0 depending on the extent of glycemic control. We know that duration of diabetes again is very important, because type 2 diabetes again is a progressive disease, as we all know, and the insulin reserve is going to get depleted gradually with years, and the body's response to hypoglycemia is also going to worsen. So if so, duration of diabetes is again another important factor. The type of treatment is very important. We already talked about that. So if somebody is sorry, is not on sulfonylurea or a insulin secretagogue, ripaglinide or insulin, then there is the risk is actually very low. So for all those people with diabetes who are not on this medication, the risk is very negligible. Again, somebody is on glyclazide or glimepiride, which are the newer sulfonylureas, again quite safe in terms of the degree and extent of hypoglycemia. Again, so that group has been given a point of 5. And self-monitoring blood glucose is another parameter. If somebody is doing it, so that is a positive thing, and that is not only going to manage diabetes, also help during fasting. Complications again are very important. You need to look into the kidney function, the GFR, the current cardiovascular disease status. So depending on that, so somebody is having unstable angina, heart failure, a GFR less than 30, is given a score of as high as 6. Pregnancy within targets or without target, score can vary from 4 to 2. Fasting hours, if it's more than 16, that actually can be also be a risk. So why it happens? So the Ramadan is followed according to a lunar calendar. So there's a difference of 10 days. So it gets preponed by 10 days every year. So again, for some it can occur in summer or winter. It can vary according to the hemisphere. It can vary according to the latitude. So if you go higher up, the days can be longer or shorter. So depending on that, so there are some areas people might have to fast for 18 hours depending on sunrise and sunset. So in those situations also we need to give a scoring for that aspect. Previous Ramadan experience. So how was the fast experience last time? That is also very important. Acute complications, again, given a strong score if it has occurred within last 3 months. Frailty, cognitive function, impaired cognitive function is actually going to be a major challenge for fasting. So we need to take that into consideration, and the degree of physical labor or activity is another scoring system. So, and it has been clearly categorized that if somebody is between a risk of calculated risk score is 0 to 3, the risk category is low. 3.5 to 6, risk is moderate. More than 6, it's high. And we can actually take a case and discuss how practically we can implement it. So we go into the case that it's a 67-year-old lady, diabetes for 17 years, hypertension, hyperlipidemia, myocardial infarction 7 years back. As such, not having any complaint. SMBG values are within acceptable range. No reported hypoglycemias. Good physical and mental function. Fasting duration will be 14 hours. So we discussed already. We can vary according to the location, the season, when the religious fasting month is going to happen, and also whether the person this person has been already fasting every Monday and Thursday. So some issues, so no issues with the earlier fasting also. So the current medication is glimepiride, 3 mg, metformin, sitagliptin, empagliflozin, has refused insulin in the past already on 4 medications: losartan, bisoprolol, rosuvastatin, and aspirin. So BP is more or less just under control. Poor pulses. So we have a recent echo. LVF is 60. Calculated EGFR is 72. HbA1c is uncontrolled. LDL 107. So if we now try to score this person in terms of risk category, we add points for each of this section. What we see is type of diabetes, hypoglycemia, glycemic control. So minimal points. Duration of diabetes gets additional point. Is on glimepiride gets a 0.5 point. Self-monitoring is being done as indicated. Stable CVD gets a 2-point score. The fast duration, again, we depending on that, if we add another point. So that way, it ultimately the risk score comes out to 5.5. So we have a moderate risk category, and there are clear-cut recommendations that how to deal with each of these risk categories. So if it's low risk, fasting is safe. The religious recommendation is fasting is obligatory. Patients may consider not to fast if concerned about safety or well-being. Moderate risk, medical evaluation is recommended. Medication adjustment is recommended. Strict monitoring during. We have a talk from Dr. Faria after related to monitoring during the fasting month. So we will get to learn from that. So strict monitoring should be done for those with moderate risk. Fasting is preferred is the religious recommendations. Patients have the right not to fast if concerned about their safety or well-being, must follow the medical recommendation. High risk category, usually if the score is more than 6, it's preferred that for medically as well as for religious reason, it's preferred that fasting should not be done. As Dr. Umesh was telling, that the pre-Ramadan counseling not only involves the patient, it should also involve the family, like all diabetes counseling. So it's not a individual disease, it's a family disease. So the overall health aspect of the family needs to change. Medication administration has to be, so in these cases, we might need to talk to them that how the medications are going to change, how blood glucose monitoring should be done. In case there is any acute complication, hypoglycemia management, we should categorically emphasize how to manage hypoglycemia. So even if we have done multiple times, that should be reinforced once again just before the month of fasting. Meal planning, adequate hydration, physical activity. So all this should come into the discussion before the fasting month. So the management plan, so we can decrease amaryl to 4 mg and plan it to iftar time. Metformin, iftar time we give 1 gram. During the morning, we give dawn period time. During suhoor, we give 500 mg. Sitagliptin can be continued. Empagliflozin as of now can be continued because the HbA1c is already high. But we need to again emphasize that empagliflozin can cause some amount of dehydration. The person needs to be very, very careful if he or she is on SGLT2 inhibitors. The other medications can be continued. Statin, LDL is not in the target range, so we need to increase rosuvastatin. And we also need to explain the fast rules when they can be broke. So if hypoglycemia occurs, or if there is hyperglycemia, and if somebody is already sick, we should also tell them that on those particular days, sick days, preferably should avoid fasting. Finally, to summarize, so we diabetes, obviously it's a broad and heterogeneous disease. You cannot set the same rules for everybody for diabetes management in general, especially if you are looking into the Ramadan month where the person is going to fast. You need to understand that different persons have different risks, and we have scientifically proven and validated guidelines. So there are multiple studies which have been done, using these guidelines, and they it's an additional benefit if we are actually giving them the right medical as well as religious recommendation on the basis of the risk they are going to fall. So hypoglycemia, hyperglycemia, diabetic ketoacidosis, dehydration, thrombosis, they are all genuine risks. The management of each of them should be explained, how the self-management related to them, how to identify these complications, how to be safe from them, and if in case that occurs, what to do on a short term, and later when is the need to get in touch with the treating doctor. So all this again has to be explained very, very clearly, and we need to quantify the risk and give them the right medical as well as the safety related as guideline related to the Ramadan month of fasting that takes place during Ramadan. Thank you. Ramadan Mubarak for the next. It's coming in the next 4 weeks. So, to all those who are listening, a very, very happy fasting for the month of Ramadan. But it's not only it's important to counsel them. We also need to assess their risk and explain to them, and also explain the risk and their management for a safe month of fasting. Thank you once again. I hand it over back to the organizers.
Thank you. Thank you, Dr. Saptarshi. Thank you for that very, very eloquent explanation about the risk stratification score, which I think is one of the most important parameters which we are now using to assess our patients as to whether they are fit to fast during Ramadan or not. Since Sir is logged in again, before I ask 2 questions to Saptarshi, which are there in our chat box, Sir, I wanted to know from you, how often is it that your patients would be at high risk by the risk stratification score and still would insist on fasting? And what kind of conversation do you have with these patients? Are you able to dissuade them from fasting, or do you just try your best to make it as safe as you possibly can for them?
Yes, thank you for this question. And in fact, Saptarshi has empowered us to give reply to your question. The risk stratification is really very good thing and very, very objective way, though we had been thinking that how to educate our patients who are really wanting to go for fasting. We had the challenges of those who have very strict control, and we had a fear. Patient also has a fear that strict control may become something worse with fasting, or the risk of hypoglycemia will be more. Similarly, those who have poor control will have a more problem, like they will have dehydration and other problem, and they may not continue to observe fasting. So if we stratify like this, I think we can educate our patients that yes, they can go for fasting, realizing that they have a high risk. And the risk is mainly because of these two. Either their sugar level is very well controlled, they are on insulin and very strict intensive intensive therapy, or they are on not very well controlled, and there will be problem during Ramadan. In fact, that will be a challenge to physician to titrate the medicines during Ramadan. He has to be very selective in choosing drugs, avoiding hypoglycemia, at the same time trying to overcome problem of hyperglycemia. So this is very good tool, and it may not be expendable in the clinic and follow it, but then they should be in the back of mind that this stratification will help in educating patients and also choosing treatment. So I think they should be allowed, because as I said in the beginning that prevalence of disease is very high and people would be observing fasting. And now it is our responsibility with the newer drugs to empower our patients to go for fasting. So even with those who have a high risk of problem during fasting, I think that can be minimized with the very judicious advice to our patients. So that can be done. The only thing that if they have comorbidity, that would be a problem. So we have to look at the comorbidity differently from this. And I think I failed to see that comorbidities were very categorically given a score in this risk stratification. So that should be a very important aspect. I think that's I wanted to say. Thank you.
Madam wants to say something, and so then I'll just quickly answer your comorbidity question before I go back to Dr. Saptarshi. Ma'am, please. Ma'am, you're muted, ma'am.
Yeah. Saptarshi, this is regarding the case.
Yes, ma'am.
See, the fasting and postprandial were grossly deranged. They were not acceptable by any means, as was the A1C. This patient was 67 years old, if I'm not wrong.
Yeah.
She's already had a myocardial infarction. And of course, ejection fraction at this point and all whatever they would have done. But I don't know, that 5.5 is a very, sitting at the fence. The risk score was 5.5. And with such deranged sugars, if it's above 300, then we have to terminate. So I would be really, really very wary of giving her the permission. But like Dr. S.K. Singh says, the question was, if they really want to go ahead, then I think for this particular individual, monitoring is extremely important. Plus, you've reduced from the glimepiride, right?
Ma'am, if the fasting, in fact, for her, the fasting and the post meal was not that bad. So the fasting.
No, it was 130 to 180 fasting.
Fasting was 120, 130s, and the post meal was 180.
The range you gave till 180.
Yeah. No.
And the postprandial was 180 to 240.
Right.
It was way up. All the postprandials were high. A1C is almost 8.9.
Right. The A1C was definitely grossly deranged. This person is actually candidate for insulin. Should be was strongly advised insulin, but again she did not accept it.
I'm just saying I would be wary of it. And then you, in that risk score, you together put gliclazide and glimepiride and repaglinide. I was just wondering, between repaglinide and the other two, which are almost at par, though we have data with gliclazide compared to CETA in the, I think, Dr. Arvind's study that they had done. but I'm just wondering, how would you put all the three in one category? I thought repaglinide would have the least chance.
Ma'am, the reason all three have been put in because I was part of these guidelines when they were
Yeah.
made. I mean,
Yeah,
and
yeah.
the reason we put all three together, to be very honest, because we have a lot of data with gliclazide. We have a diet Ramadan study, and actually Arvind sir's study, ma'am, at that point of time showed that gliclazide had a lower incidence of hypoglycemia even compared to sitagliptin.
Yeah,
Sitagliptin was used as the comparator at that point of time. Repaglinide per se does not have too much of data, ma'am. But the reason we put repaglinide in the same category was because though the data was not available as a scientific, algorithm, it was a drug which does not cause too much of hypoglycemia, and we've seen that when we use it a lot in our patients during Ramadan.
Yeah,
So,
exactly. That's what I do. That's what I wanted to ask the house. I mean, quite often I shift my patient to repaglinide, rather than continue with the glimi or the glicla.
Remember, the data with gliclazide show that you don't need to switch. The data with gliclazide shows only if you change the timing, especially if the patient is extended release gliclazide, the incidence of hypoglycemia, even in the Indian subset, was only 0.2%, ma'am. And what was seen was that actually what influenced hypoglycemia was the timing of suhoor. If the time of suhoor was as close to starting the fast, as close as possible, then the incidence of hypoglycemia was much lower, ma'am, in those patients, rather than if they did not take suhoor or if the suhoor. So one of the variables was that part of the fast where the timing of suhoor made a very big difference to hypoglycemia. So the international data, ma'am, because internationally repaglinide is not used that commonly. So most of the data which came out, ma'am, when we analyzed all the OHA, the SU data, was seen with gliclazide more than even with glimepiride. The glimepiride data was the Al-Safri et al. Group data, which had glimepiride and gliclazide in some groups. And that's the reason why we put that as 0.5, because the hypoglycemia risk was much lower. And we are putting those point systems in place regarding OHAs. The older OHAs, ma'am, are not used very much internationally. That's the reason it didn't go in that point system at all, ma'am. And that was the entire thought process. Ma'am, the entire thought process of putting these patients as mild, moderate, and severe is that patients who are mild, who come in the mild category, are patients who are allowed to fast, who are actually said that, yes, you can fast and you should fast. The case which Saptarshi just discussed, ma'am, a moderate, he's got an elderly patient who's going to insist on fasting, irrespective. That's what, of course, correct me, Dr. Saptarshi, if I'm wrong. But these are those group of patients who, whatever you tell them, are going to say, I am postmenopausal. My entire family is going to fast. And if I don't have any very, very big reason not to fast, I would love to know what the opinion of the house is. I am going to actually fast. And then those are the gray zones. Ma'am, the moderate risk patients are patients who are allowed not to fast. I mean, we can tell them, okay, you are allowed not to fast, but if you insist on fasting, as you said, the monitoring is which will make a very big difference. The high risk patients, ma'am, are told you just cannot fast. But the conversation has changed. We tell them, we want you to fast, but unfortunately, see, this is your risk score. This is where you are. So the risk stratification has helped us in those ways a lot, ma'am, in having a little black and white as to which patients can fast and which patients cannot fast. And that's, I'll stop over here, ma'am. Otherwise, I can go on and on. I will ask some questions which I want to ask him.
Gliclazide, USA not approved, right? All others, gliclazide approved. So there's no gliclazide there, which we can even talk about.
Yes, they use glimepiride, ma'am.
You're saying repaglinide less in the, like Saudi, that's in the Middle East, let's say. Here we have all the three. Amongst all the three, I think glimepiride is the most prescribed, if I'm not wrong. And that means you would not switch your patient from glimi to glicla. This is just another very silly question perhaps, but I don't think that would make any sense, right?
No, ma'am, it really wouldn't make sense. I would just stop the morning dose of glimepiride and just tell the patient to take the glimepiride in the evening.
That's what he just said. Thank you.
Dr. Saptarshi, two quick questions which a doctor from Indore wants to know is that how much do your patients actually monitored? How much are they really willing to prick themselves during Ramadan? Is there still some myth around pricking during Ramadan that they cannot prick, or are they allowed to prick? That's what I think Dr. Mohinte
I
wants
think
to
we have a whole talk dedicated on that. So Dr. Faria will be taking that up. Obviously, so there is a myth that pricking is not allowed, and so we need to discuss with them that it can be safely done without any issues. And Dr. Faria will be taking this whole session whether we need to do whether we can have a continuous glucose monitor. So we will have a dedicated discussion on that. That is the next talk which is coming up.
The last question, which also Dr. Jagannath wants to know, is the practical applicability of the risk calculator. I mean, how easy or difficult is it to actually do in clinical practice? There is an app available, but even then he wants to understand from you what is the ease of being able to apply it in clinical practice. Should they do it for all their patients? They do it for selective patients?
So I think that's a very, very valid point. So maybe if somebody is on a metformin only or a metformin DPP4 combination, so and it doesn't have that much of complications, so automatically that person will get a low risk score. So it's the hypoglycemia as well as the and on top of that, if somebody is having H1C of 10, obviously the risk will go up. So if well controlled diabetes, you're looking at him or her and see H1 say 6.5 or 7 is on metformin, 3-4 years of diabetes, no additional complications. So you can maybe omit the scoring because you know the score is going to come to low risk. But whenever somebody is on a sulfonylurea, insulin, has complications, and has had previous history of hypoglycemia, had difficulties with fasting, so these are the areas where actually you need to. So this is not a score which is going to take a lot of time. So it's going to take maybe maximum 1 minute or so to add on. If you are, it's not a very complicated score. So we all have busy OPD, so doing any type of scoring becomes a challenge. So this is something which some of the patients who are educated can fill up themselves also. And maybe if you train your support staff, so while the patient is sitting in the reception, they can, if somebody, your diabetes educator is there, a nutritionist is there, even they can do the risk stratification score. So we if you are having any confusion, we have an objective way to assess it, that whether we can go ahead with whether the person can go ahead with fasting or should be for medical and as well as religious recommendation should be avoiding it. So not a very complicated risk scoring system. It's a simple one, and we should try to incorporate, at least for people like this where we are having doubts. Person is on sulfonylurea and H1C is 9 point something, and already had a CAD. So GFR was normal, 72 in this case. So creatinine is slightly high, otherwise maybe 1.5, 1.6. The GFR calculation will come down to less than 60 or less than whenever it's higher up. So all these things we need to take into consideration, and they have given a very, very high risk score for hypoglycemia unawareness. So that is something. If somebody is coming to you with comes with a fasting and PP of say 64 and say 180, and is not aware that was having hypoglycemia at the time of collecting samples, we really need to be careful for those people.
Accepted, totally accepted. I don't think it could be clearer that yes, please do the risk stratification score. It's easy to do, it's simple to do, and it would help you in comparing your patient not only during that Ramadan, but also to the previous Ramadan experience. Thank you, Dr. Saptarshi, for that.
Thank you.
Thank you very much. And over to Dr. Amal and Dr. Siddharth for introducing ma'am.
Thank you so much, Saptarishi sir, for enlightening us on risk stratification of patients in Ramadan. And now I would like to invite Dr. Faria Afsana ma'am Ma'am is Associate Professor, Department of Endocrinology, Birdam, Dhaka. Ma'am is also President-elect in South Asian Federation of Endocrine Societies, Bangladesh Endocrine Society, and ma'am is a fellow at American Association of Clinical Endocrinologists with around 76 publications in different national and international journals. Ma'am will be speaking upon glucose monitoring in Ramadan. Over to you, ma'am.
Thank you. Thank you for the kind introduction. Let me share the slides. And before that, good afternoon, Sarita ma'am, Dr. Shala. Thank you for inviting me in this session. And it is a great pleasure and honor for me to be here with this session. And greetings from Bangladesh. I think my slides are visible.
Yeah, it's visible.
Okay. So in next couple of minutes, I like to highlight few points regarding the glucose monitoring. First of all, the available devices and the glucose monitoring during Ramadan, time to do the blood tests and targets of blood glucose according to the monitoring devices, and what to look for in the blood test during Ramadan fasting. And last, the question asked by the audience, does a blood test while Ramadan fasting nullifies the fast? So let's start with the available devices. We have the self-monitoring blood glucose, as the diabetic patients are using for a long time, the glucometers. These are the finger prick devices to draw a drop of blood from the finger, and the monitor shows the result just within 10 seconds or much less. And this is used throughout the year, but more useful during the Ramadan fasting. The other methods are continuous glucose monitoring. It is a teeny sensor inserted under the skin and automatically measures the blood glucose level and transmits the information to a monitoring device, and also provide hypo and hyperglycemic alert. That is a very important thing. And the newer device is the flash glucose monitoring device. It is an interstitial system of monitoring blood glucose and required user calibration. And a patch sensor is fixed on the back of the arm, and a hand reader is used to scan the sensor to receive the glucose reading. And it is sometimes available in the mobile also, and it is connected to the mobile. So it is very much easy for the patient to read the minute-to-minute blood glucose even. So what is the difference between the self-monitoring blood glucose and the continuous glucose monitoring? If we look at the main difference, that is the operator dependent is the self-monitoring blood glucose, and it captures the immediate changes. But in the interstitial glucose reading, it may be lagged behind 5 to 15 minutes from the plasma value. So the glucose level, when changed quickly, as that of some after exercise or treatment of hypoglycemia, the result of blood glucose may not be immediately available in the CGM. On the other hand, in the self-monitoring blood glucose, the result reflects at the moment it is taken, and measures in the CGM, it measures the sensor when the sensor is on, and provide results every few minutes. And the blood sugar needed according to the treatment plan, that is self-monitoring blood glucose, is very much helpful. And the sensor in the CGM can be one for an extended period, 7 to 14 days. It may be changed at 7 to 14 days interval. And in the self-monitoring blood glucose, there may be an user error, inadequate and contaminated blood sample, expired or damaged trace strips. That can be a faulty technique and may give faulty results. That is not a problem with the CGM, but some insertion problem or miscalibrated sensor or detachment of the sensor and hypersensitivity reaction may be there in the continuous glucose monitoring. So there are pros and cons in the both self-monitoring and the CGM levels. So what is the idea of their guidelines recommend? They recommend that use of CGM as the method of choice if available for the patients with diabetes who observe Ramadan fasting. So it is a very valuable tool, but the patients who do not have or not available CGM value, glucometer is a very good option. That is self-monitoring blood glucose is a very good option for them also. And the studies have indicated that CGM and the flash devices provide the benefit of predicting hypoglycemia and assessing glycemic excursion during Ramadan fasting, and also can make comparison with the non-fasting and the pre-Ramadan and even the post-Ramadan blood glucose values. Next, the glucose monitoring during Ramadan fasting. And the key component, one of the key component of Ramadan-focused educational program is the blood glucose monitoring. So from the time now on, that is we are just heading 4 weeks from now, the Ramadan. The pre-Ramadan education should also include the education about blood glucose monitoring. So it is a key component of the Ramadan focused educational program. So glucose monitoring is the cornerstone, especially during Ramadan in patients who are at risk of hypo and hyperglycemia. And as food abstinence is there for a longer period of day during the daytime in people treated with sulfonylurea and insulin, they predispose it to increased risk of hypoglycemia. For them also, blood glucose monitoring is very much important. And dose adjustment made during the Ramadan fasting, as there may be we actually pre-planned dose reduction is done during the Ramadan fasting, but due to the huge carbohydrate intake, there may be or different episodes of hyperglycemia even, that is also may be detected by this monitoring of the blood glucose. And the EPIDARE study results showed that physician educated participants about blood glucose monitoring in 89% of type 1 diabetic patients and 80% of the type 2 diabetic patients, but only 67% of the type 1 patients and 37% of the type 2 diabetic patients reported actually monitoring the blood glucose level. And the discrepancy is mainly due to forgetfulness. The patient is not aware of the monitoring and importance of the monitoring. So pre-Ramadan education is very much important. Misconceptions about the pricking fingers during the fast, either he or she can prick or it can nullify the fast, and a lack of insurance coverage in that countries, and cost may be an extra steep cost may be a factor for not doing the regular glucose monitoring. So extra monitoring actually is required during the Ramadan fasting, especially those who are on anti-diabetic medications, taking sulfonylureas and insulin, and participating in the long Tarawih prayers may increase the glucose utilization, and there may be a chance of hypoglycemia, and of course for the elderly diabetics. And another group of patients, for the time to do the blood test during the Ramadan fasting, it is very much important when to do the blood glucose monitoring. If the patient has moderate to low risk individual, the diabetes can be monitored once or twice daily. But most of the monitoring in the first few days of the Ramadan fasting, a frequent, careful watch of the blood glucose should be done. And those at high risk, though high risk are a risk category, according to the risk category, are very much forbidden for the fasting. But in some patients, we obey or respect the patient's wish, and they allow the patients, though they are high risk, but they are allowed to fast. In that case, it's actually a 7-time point guide monitoring should be done. And according to the ITF-DAR guideline, the 7 times should be a pre-dawn meal in the morning, in the midday, in mid-afternoon, and in the pre-sunset, that is before iftar, and at any time when there is a chance of hypo or hyperglycemia, or there is a symptom of hypo or hyperglycemia and the patient feels unwell. So at least in these 7 points should be practiced in the earlier days of the Ramadan fasting to avoid the hypo and hyperglycemic complications. Another important thing, decision of breaking the fast. That is also important thing and can be monitored. If careful monitoring can help in breaking the fast and decrease the health hazards due to hypoglycemia and even hyperglycemic crisis. If the blood glucose is less than 3.9 millimole at any time of the day, the blood glucose, the fasting should be discontinued. And if it is very much near to the iftar time, and then 1 hour after that, another blood glucose can be checked. And if it is between 3.9 to 5, the fasting can be broken. And if it is more than 16.6, this is another criteria for breaking the fast, as it may cause hyperglycemic crisis. And so as there is sometimes the patient has hypoglycemic or hyperglycemic symptom unawareness, in that case, blood glucose monitoring is a very much important tool for helping them to prevent the acute complications. Next, another issue, the pregnancy and fasting. Actually, pregnancy is an exemption for fasting, but nowadays many pregnant women choose to fast during Ramadan. A detailed discussion should be done about the risk stratification, and diabetic pregnant women will strictly monitor their blood glucose level to prevent hyperglycemia almost daily, because there may be day-to-day variation, and in the prolonged fasting, there is a chance of ketonuria in patients with pregnancy, and there is a chance of hypoglycemia even. So for them, they carry out their self-monitoring blood glucose before iftar, 1 to 2 hours after meal, once during the day while fasting, particularly in the afternoon, and anytime they feel unwell. Next, the target of blood glucose during Ramadan fasting. That is very important. at what level the blood sugar should be kept, and at what time the patient will think that there is a chance of hypo or hyperglycemia. Before sure, it should be good to keep it is between 120 to 140 milligram per deciliter. In the mid-morning, it may be 140 to 180. Midday, 120 to 180. And before iftar, it should not be less than 70 milligram per deciliter. And in 2 hours after iftar, as there is a chance of hyperglycemia due to heavy meal in the iftar, it should not be more than 180. So throughout the day, around 8 to 10 is good. And in the pre-iftar period, it should not be less than 3.9 millimole per liter. Next, what to look for in the blood test during Ramadan fasting. If we look at the study result, here the mean 24 hours continuous glucose monitoring profile derived from the patients with diabetes during Ramadan and the non-Ramadan fasting period is compared. And this blue line is the non-fasting period and the red line is the fasting period, but it is very much visible that during the pre-iftar time, the blood glucose is very much low, there is a sharp rise in the post-iftar, and then the same that of the post-suhoor period also. So there is an increased meal, and this record can be compared with the pre-Ramadan. So to avoid the glycemic variability, blood glucose monitoring is a very much important tool to avoid this hypo and hyperglycemic episodes. Next, this is a study result where a mean interstitial 24 hours glucose profile measured by CGM in patients with type 2 diabetes before and during Ramadan, and greater glycemic variability was demonstrated during Ramadan, with lower in the pre-iftar followed by a peak post-iftar in the second smaller rise post-suhoor. And this is showing the fasting and the feeding period, which is compared with the pre-Ramadan value also. So diet should be properly advised, and glycemic monitoring will help to avoid this glycemic variability. This is another study result I like to share. The initial increase in blood glucose variability during Ramadan fasting in non-insulin treated patients with type 2 diabetes using the continuous glucose monitoring was studied. And this study examined the effect of Ramadan fasting on interstitial blood glucose variability in early, late, post-Ramadan compared to the pre-Ramadan days in type 2 diabetic patients who are not requiring insulin. And this is the study design. The CGM was inserted to the patient in 2 to 3 days before Ramadan fasting and kept up to 3 to 4 days up to the first few days of the Ramadan. Actually, total six days the CGM was inserted. And in the later part of the Ramadan, from the 27th Ramadan up to the 4th to 5th day after Eid, the CGM was again inserted. So a 6 days, 2 episodes, CGM record was monitored. And this is actually the result showing the mean amplitude of blood glucose excursion. That is, in the pre-Ramadan and the early Ramadan, there is a variation in the mean excursion of the blood glucose, and which is returned to the pre-Ramadan level in the later part of the Ramadan. Male patients and treatment with sulfonylurea is another risk factor for fluctuation or glycemic excursion in the form of hypoglycemia, but there is no variation or change in the total events of hyperglycemia or hypoglycemia, and the time in range is almost similar throughout the Ramadan period. This is another study showing the short-term glycemic changes from continuous glucose monitoring among children and adolescents with type 1 diabetes mellitus during fasting in Ramadan month. As we all know that type 1 diabetes is another risk stratification factor for Ramadan fasting. But this study was done with the type 1 diabetic patients in 2020 in Malaysia. And type 1 diabetes and children who intend to fast, structure pre-Ramadan focused education and standardized glucometer was provided, and a retrospective CGM data was also collected. And there is a study of time in range, hyperglycemic episode and hypoglycemia. And the hyperglycemia is a little higher during the Ramadan period. The time in range is mostly maintained before Ramadan. So Ramadan is a risk factor for higher level of hyperglycemia in this study population. And regarding the glycemic variability with mean amplitude of glycemic excursion, there is a significant difference than that of the non-fasting period of time. So for these patients, type 1 diabetes glucose monitoring give valuable result in controlling diabetes throughout the Ramadan period. So flash glucose monitoring device empowers the patient with type 1 diabetes to fast safely during the month of Ramadan, and adult patients with type 1 diabetes were monitored with flash glucose monitor were available, though it is not still available routinely in Bangladesh, and also this can helpful in Ramadan fasting for glucose monitoring. And this is another study result which shows the most frequent time of hyperglycemia, that is mostly between the dawn and afternoon, that is for the higher meal intake during the suhoor period. And most frequent type of hypoglycemia is afternoon, that is the before iftar, and afternoon is the most important time for hypoglycemia. And the glucose variability in this study is mostly during Ramadan time period compared to the pre and post Ramadan period, and also the time in range before, during, and after Ramadan is almost similar in 2 weeks after during Ramadan and 2 weeks prior to Ramadan. So the last question, the question asked by one of the audience, that does a blood test while Ramadan fasting nullifies the fast? And each and every year we face this question from different patients. And the religious scholars of Egypt earlier mentioned that safety of fasting while during SMBG is not hampered. And a recent decision made by the in Jakarta Fatwa Commission in 2000 stated that bleeding from the fasting people, including blood donation and blood test, did not cancel or reduce the virtue of the person's fasting. And it is permissible to take a blood test while fasting during Ramadan, and it will not break the fast. And we in our country, Bangladesh, we in our national mosque, Imam also gave the religious statement of glucose monitoring and even insulin injection if required. Sometimes the correction dose is even required, that may be given during fasting period, and it will not break the fast. And we use these posters for educating the patients in our setting, to educate the patient about this issue or myths of breaking the fast with self-monitoring blood glucose. So if I summarize, glucose monitoring by self-monitoring blood glucose or CGM is an extremely important aspect of Ramadan fasting for people with diabetes to avoid hypo and hyperglycemia, and also dehydration, as hyperglycemia may lead to dehydration and the development of diabetic ketoacidosis that can be avoided during Ramadan fasting by proper monitoring, by self-monitoring blood glucose or CGM. And people with diabetes need to be given education on how to monitor their blood glucose and what is the target and when to break the fast. And a 7-point self-monitoring blood glucose guide can be adapted for individuals who are very much in high risk, elderly patients, or in pregnancy, and with better control of diabetes, and the patients who are on insulin and sulfonylurea. So continuous glucose monitoring by CGM and flash glucose monitoring is also a good option. Thank you. I like to conclude my talk with the wish for the diabetics to stay healthy this Ramadan with smart diabetes management system. Thank you.
Thank you very much, ma'am, for such a nice and elaborate. I think you have covered all the aspect of blood glucose monitoring during Ramzan so well. In fact, there was a question in chat box also, that whether the taking venous blood sample break the fast or not. I think that too you have already covered, that taking venous blood glucose, I think does not invalidate the fast. In fact, taking injections also, they does not invalidate the fast. So that is there. So if you want to add anything, because that's the question from one of the panelists also, whether taking venous blood glucose samples during fast. I don't think there is any
Actually
issue,
not.
ma'am.
For the disease management and to know the levels, for the venous blood glucose testing will not break the fast.
Another question is that, and I would also like to know the opinion of SK Singh sir and Bajaj ma'am also, along with you, ma'am. What is do the patient, because many times the patient who is wearing a CGM, they are in think that they don't need to do SMBG. So is there any circumstances, or are there any circumstances in the patient who is wearing a CGM but they need to do SMBG also? Your take, ma'am.
Okay, madam will tell. All right.
Maria.
Yes, so there is a chance of CGM failure also, because kinking of the tube or the scoring or the monitoring failure, the patient feels unwell in spite of the CGM, because CGM monitor sometimes flash glucose monitoring, that is an important thing. The patient can see the record in the hand devices. But for the CGM, we get the report 3 or 4 days after the application. In that case, it may be difficult for the patients, especially for those who have hypoglycemia unawareness or hyperglycemia doesn't feel like that. In that case, the glucometer monitoring, self-monitoring blood glucose is the best device. The patient can monitor just at the time he wish. But flash glucose monitoring actually solve the problem. If available, then it will be a good option to see. And there is another thing, it is actually lagged behind because it is the interstitial report. In that case, in even a hypoglycemia treatment, the patient, the blood sugar rise earlier, but the interstitial report show a little late report. In that case, also self-monitoring blood glucose is very much important to see the actually the diagnose the hypo and hyperglycemia events at point of time, and also the recovery point also.
Bajaj ma'am, your comments on this, ma'am?
See, self-monitoring has been with us for definitely much longer. We have more, let's say, know-how, knowledge about that. And even with patients on the pump, even if the patient is on the insulin pump, they still need to monitor. I mean, very few of them are on those high-end pumps where they have this automatic sensors which will tell about the blood glucose. But I think the mainstay will still be self-monitoring. CGMS has its drawbacks, like Faria has highlighted very nicely. So immediate management is the immediate awareness. Yeah, this is the blood glucose level at this point in time, or point of care, which we actually, the term that we use more for A1C than anything else. The blood glucose at that point in time. That is crucial, especially when she highlighted that before iftar, it should not be less than 70. And after the so-called, after iftar, it should not be more than 300. Because I think one really needs to check a couple of days to be sure that that feasting is not going overboard.
Another question is that
muted.
Another that what should be the timing of exercise if someone want to do physical activity during Ramzan? What is the best possible time, and how they monitor blood glucose in that period?
Yeah, Faria.
Actually, during the fasting period, we always advise the patient not to exercise during the fasting period, because there is a chance of hypoglycemia, overwork, and there is every chance of hypoglycemia. And actually, the Taraweeh prayer, the patients who practice the Taraweeh prayer, that actually is sufficient for the daily exercise. But in spite of this, if the patient wants to exercise or have brisk walking, they can do after the dinner or after Taraweeh prayer at any time, but in the house premises, not for a very far or long walk or very vigorous exercise.
Absolutely, ma'am. I agree with you, because Taraweeh prayers, they are almost a moderate amount of exercise which is recommended for diabetics.
Yes.
So if they are offering Taraweeh, then there is no need for more exercise. But
yes.
if someone is enthusiastic, then definitely they can choose
Light
the time.
exercise, but between iftar and sehri, of course, iftar and suhoor.
Yeah, if they really get up early, why not exercise before, at that time when they get up? If they're used to getting up, they're specifically getting up. If that is their daily routine, can they?
Actually,
why
madam,
not exercise before, first thing in the morning? Of course, I agree. After dinner, immediately after dinner, they can't do it. They have to wait at least half an hour. Right? And
actually,
sunrise would be 6 p.m.ish, right? 6 to 6:30 p.m.
Actually, the suhoor time is much earlier than that. And the patient actually sleeps after the dinner and there is very short time, very rush about the suhoor meal to prepare and then take the meal. So there is very little time to exercise at that time. And in that case, after the Tarabi prayer, they have time to exercise, or 1 hour after dinner. That is actually not the patient actually work at that time. Another important time they can make time to exercise is 1 hour after iftar also. But that is a very close time to Tarabi prayer. That is also very difficult to make. Or any 10 to 15 minutes brisk walking can be done 1 hour after iftar, or after the Tarabi prayer, or 1 hour after dinner.
Yeah, and many patients are also quite comfortable in the morning after the Fajr prayer. After the suhoor, if they have finished their Fajr prayer, and if they want and if they have time, they are comfortable, then they can do it.
In that
And
case, after the suhoor prayer, that is the Fajr prayer, there is during the fasting period, during the Ramadan fasting, actually that is not the time, not will be the good time for exercise, because the whole day is remaining without meal. So I think that will not be a good time for exercise.
yeah, and another thing which we can tell the patient, at least they should exercise, avoid exercise prior to iftar, because that is the most important time for hypoglycemia. So there can be a problem. So that is the time which we should forbid our patient, that is the time when you should not exercise, because that definitely can lead to so much of problem. Rest of the things and previous years experiences, they also count so much. So if the patient has some kind of experiences, because many times I think more than the physician, more than the guidelines, all those things, it's the patient who teaches about Ramadan in OPD, because they have got so much of innovation and all those permutations and combination of different kind of things. So their previous experience, they also count. That's the thing.
So exercise, you cannot deny the importance, but the timing would be critical. There are absolute no's, but not before iftar. That's a very clear-cut no, and not during the period of fasting. So over and above that, you just have to sort of find some window. At least a 15, 20, half an hour is good enough. I think half a 30-minute window, if they can get their regular. I think most of them walk. People who are really fitness freaks, they might go ahead with their fitness routine. But they can do the resistance exercises.
Yes, not the vigorous exercise. And of course, it should be individualized.
Yeah, absolutely. Absolutely.
Okay, thank you, ma'am. Now I would like to hand over the thing to Dr. Amal and Dr. Siddharth. Please go ahead.
So, coming to the next presentation, so slide, please. So coming to the next presentation, so I heartily invite Dr. Saqib Ahmed Khan. Sir is a consultant in Chandan Hospital, Lucknow, and he is also a member of the Endocrine Society of India, ISPEA and RSSDI. And sir has also done MRCP, SC, diabetes, and so over to Saqib, sir.
So good evening.
I think there is another speaker also. You can.
Yes, sir. Yes, sir. Sure.
Yeah.
And joining with him, so joining with the sir.
Can you have the CV slide, please?
So joining with
Dr.
us, sir.
Hamad. Yeah.
Joining with us, sir, is the Hamadur Rahman, sir. Sir has done MD at BHU and DM endocrinology at from AIMS Delhi, and sir has also received Epicon Gold Medal award for MD medicine, and sir is also a receiver of MMS Ahuja award from AIMS New Delhi, and sir has also got several publications in both national and international journals, and has also authorized various several textbook chapters. So over to you, sir. Over to you, sir.
So good evening, everyone. Thank you, ESI, and thank you, everyone who has presented this opportunity to us. So we would be continuing the discussion about the safe Ramadan. we know that it is a spiritual benefit. It is a spiritual journey which benefit a patient who adopts it. But yes, religion makes it easy for us. He never say that we should have it hard for us. If we can have it with safety, then definitely we can go with it. And otherwise, we should have uh, a prior assessment, and we can avoid it, or we can give kafara in place of the Ramadan fast. So, but if a patient has decided, or we have decided that the patient is deemed fit, then what are the changes which are required? We know that, like the diabetes management, the purpose of treatment of diabetes is prevention of complication, and like is the case with diabetes in Ramadan period also, we tend to advise our patient that these small and frequent meals are the cornerstone of most of the patients with type 2 diabetes. But it's not the case with Ramadan period. So we have the challenges of hypoglycemia when we are having a prolonged fasting for more than 16 or 18 hours, even in some part of the world. And with more eating at the time of suhoor, the risk of hyperglycemia, more risk of feasting after the fast, has been discussed, the risk of those acute complications with hyperglycemia, that is DKA and dehydration, and consequent the risk of thrombosis. So how we can avoid it? So just a brief about the different classes of drug, and then we would be discussing in length. So metformin, we know, is a low risk option in most of our patients. It is the first line therapy. Usually no dosage modification required, especially in case of Ramadan per se. We can split the dosage. Suppose if the patient is taking 1500 milligram, we can split 2/3 at the time of sunset or of iftar time, and 1/3 at the time of pre-dawn or at the time of suhoor. Sulfonylurea, we know that it is a high anti-hyperglycemic efficacy agent which can be required in a lot of patients, even during Ramadan period. But the newer generation sulfonylureas like glimepiride, gliclazide, and the short-acting like glipizide are preferred over conventional sulfonylureas which were used in the past, which were having the more risk of hypoglycemia because of the long mechanism, long duration of action, like glibenclamide. TZDs, they also have a very low risk of hypoglycemia, and they also have a high anti-hyperglycemic efficacy, and no dose modification would be required if the patient is having a good glycemic control on them. Non-sulfonylurea secretagogue like glinides, they also pose some risk, and we would be discussing about their evidence which we have in Ramadan period. No dose adjustment may be required. GLP-1 receptor agonist, DPP-4 inhibitor, they per se, they also have a very low risk of hypoglycemia. SGLT2 inhibitors, we are having some studies with temperate countries, but we will be seeing that they will have to be used with a lot of caution if we decide to do so. And insulin would be covered in detail by the next speaker. So metformin, when we talk about, it is the first line agent for almost all the type 2 diabetic patients, until unless it is contraindicated, or when it is not tolerated due to GI problem, should be duly prescribed until unless it is contraindicated. As I've said, it can be divided as a 1/3 and 2/3 in suhoor and iftar time respectively. We are not having any randomized control trial to compare metformin against the other options, but it is a molecule which we have been using for a long duration of time. When we talk about another short-acting option, that is alpha glucosidase inhibitor, though there is no randomized control trial available on AGI effect during Ramadan period, but we know that in a non-fasting group, it is having a very low risk of hypoglycemia. It is having a mild weight loss. There is no cardiovascular sequel. There is modest HbA1c reduction with this drug. Effect may be limited by its GI effect, but the good thing is that its side effects are related to, or they are in proportion to the dosage required. So we can use the smaller dosage which would be required, so that the patient can tolerate The twice daily dosing during Ramadan period with the omission of lunch dose may reduce its GI side effects, which are dose dependent. TZD, out of which pioglitazone, which we are using widely, it is widely approved and used type 2 diabetic in type 2 diabetic population. There is only one study that looked at the effect of this drug during Ramadan period, which has shown no significant difference in the hypoglycemic episode between the two arms. The pioglitazone showed better glycemic control throughout the study period, as evidenced by the lower stable fructosamine value in that study. But we'll have to keep in mind that these agents, these PPAR gamma agonism, they require at least 2 to 4 weeks to exert substantial anti-hyperglycemic effect. Therefore, these agents cannot be quickly substituted for agents associated with hypoglycemia. Suppose if the patient is not doing good with the sulfonylurea, they are having hypos. So if we give, or if we replace them with pioglitazone during the Ramadan period, it would take at least 2 to 4 weeks of time to have its maximal effect, and that is why it is not good to change during the Ramadan period. If we have pioglitazone before the Ramadan period, it can be a good option. So though we also know that it tends to have some weight gain because of the fluid retention, that we can use when we are choosing a specific option for our patients. But if it is even for this much of short duration, we can use it. Insulin secretagogue like sulfonylurea, which can be debated as the most commonly prescribed oral anti-hyperglycemic drug during Ramadan period. They and the short-acting secretagogue like glinides, they both are estimated to reduce HbA1c by 1 to 2% compared to placebo in non-fasting population. Shorter-acting sulfonylureas like glimepiride and gliclazide, especially the sustained release, they have shown comparable glycemic control with minimal hypoglycemic events when compared with ripaglinide. In an observational study during Ramadan period, glibenclamide reported the highest incidence of severe hypoglycemia compared to those who were on glimepiride or gliclazide. Some studies have shown the lowest hypoglycemia risk with the gliclazide. Lowering the dose of glibenclamide didn't seem to reduce the hypoglycemic events during Ramadan in those studies. So even with lower dosage, it is not safe. When we talk about the DPP-4 inhibitor, which is a moderate anti-hyperglycemic class of drug, but it is one of the safest option. The RCTs which have examined the vildagliptin versus gliclazide in patients on a background of metformin therapy, there was no significant difference in the glycemic control in those arms. Vildagliptin had significantly lower confirmed hypoglycemic events as compared to the gliclazide group. Patients with longer duration of type 2 diabetes with suboptimal control, when they were prescribed with vildagliptin during Ramadan, they have shown significantly lower hypoglycemic events compared to the gliclazide. We have plenty of data for vildagliptin, like with real world studies like Virtue and Vector, and randomized control trial like Steadfast are available, which attest to the safety of vildagliptin when it is used in the Ramadan period. SGLT2 inhibitor, we have some studies, but still will have to be clear that in a country which is not temperate and where the genital myocardial infection are much more common as compared to the textbook which we read, we'll have to be very cautious when the patient is fasting for more than 12 or 14 hours, and when the patient is having more risk of dehydration. So we should only allow this class of drug when the benefit outweighs the risk, and the patient can fast safely. In an open label study comparing the dapagliflozin versus sulfonylurea on the background of metformin therapy, the results have shown that fewer patients in the dapagliflozin arm experienced symptomatic hypoglycemia, which was quite less as compared to sulfonylurea, or documented hypoglycemia, which was also quite less, which we expect also. Another study with a real world observational, which was a real world observational trial, with dapagliflozin or canagliflozin being used on top of insulin or other oral anti-hyperglycemic drug have shown that on top of those other options, it was having risk of hypoglycemia to the tune of 27%, and 9.3% were having the symptoms of dehydration during Ramadan. When we talk about the GLP-1 receptor analog, it is an attractive option in patients with type 2 diabetes. Like Treat for Ramadan period has shown that if in a 12-week trial where patients with type 2 diabetes were randomized to receive either liraglutide up to 1.2 milligram per day or sulfonylurea in addition to metformin, in that trial, more subjects in the liraglutide arm tended to achieve the composite endpoints compared to sulfonylurea and with lesser risk of hypoglycemia also. But even before Ramadan period with titration, many of the patient they tend to withdraw. Many of the patients were withdrawn because of the GI side effects. So we cannot start this molecule during the Ramadan period. We know that in the initial in initial phase, the GI side effects would be higher, especially with the shorter acting GLP-1 receptor agonist. If the patient is doing good with the stable control with GLP-1 receptor agonist, yes, it is having a low risk of hypoglycemia. We can continue. So in another observational study, it has revealed that 16% of hypoglycemic events were when liraglutide of at least 1.2 milligram daily was added on top of other anti-hyperglycemic drugs. There were no severe hypoglycemic events though, which were requiring hospital admission. So just again summarizing, so if suppose if the patient is on diet and exercise and he is doing good, we can just have an explanation about how to have change in diet, in exercise, how to have adequate fluid intake when the patient is not fasting, how to avoid the postural dizziness when the patient is going for those long 20 rakats or so in the Tarabi phase. When the patient is on oral hyperglycemic agent, we must ensure the importance of having adequate fluid intake after the period of breaking the fast, that is iftar, and till the patient is taking the meal at the time of suhoor. He should have adequate fluid intake even between those rakats of Tarabi. When the patient is on metformin, we can divide it in the form of 2/3 at the time of iftar and 1/3 at the time of pre-dawn meal, or we can continue the same dosage. When the patient is on a stable control with TZDs, alpha glucosidase inhibitor, or incretin based therapy, there is no change which is required. Sulfonylurea once a daily. If the patient is doing good, then according to the patient's patient glycemic status, we can give it at the time of sunset meal. If the patient is taking twice a day sulfonylurea, we can give half the usual morning dosage at the pre-dawn meal and the usual dose at sunset meal. If we can replace it, we should replace it at sufficient weeks or months before the patient intends to fast. So just to conclude, a dose modification alongside a stricter schedule of self-monitoring blood glucose, the benefits of which have already been explained by the previous speakers. It is very important. They will help in ensuring a safe fasting with good glycemic control during Ramadan. Individuals on multiple anti-diabetic therapies, they need individualized dose reduction to avoid additional risk of hypoglycemia or hyperglycemia, just to make their fasting safe. So with this, I would end here and invite Dr. Hamadur Rahman Boss to present his part.
Good evening to all of you. At the outset, I'd like to thank Endocrine Society of India for giving us this opportunity to talk on this important aspect of Ramadan and diabetes. I would like to thank Sela ma'am and Dr. Hamid for giving us this opportunity. I pay my regard to Professor Bajaj and Professor S.K. Singh sir, who is also my teacher in BHU. So let me have my presentation. Is my slide visible and I am audible?
Yes.
Yes.
Just 1 minute. Yes. Thank you, Dr. Shakib, for a wonderful presentation on oral hypoglycemic agents, how they should be modified during the month of Ramadan. And myself will talk on insulin dose modifications during the month of Ramadan. So we know many people with diabetes, particularly type 2 diabetes, are on insulin therapy to control their diabetes, and a variety of insulin regimens can be used. And insulin used during fasting carries a significant risk of hypoglycemia, especially when more complex insulin regimens are used. We know our population, they are afraid of insulin because of two reasons. One is prick, another is risk of hypoglycemia. And this insulin to take in the month of Ramadan, when they are not able to take for 14 hours, 15 hours, 16 hours, so that basically bit difficult to understand them, that they will not face any untoward side effect or any incidence of hypoglycemia. So that's a major challenge to the physician to make them understand that they are going to have a normal lifestyle. They are not going to have any episodes of hypoglycemia. So extra care and caution must be taken when developing Ramadan medication regimens. Let me tell you, as Dr. Faria Afsana told, pricking fingertips for blood glucose testing or taking blood samples, or even told blood donation does not invalidate the Ramadan fast. So here also, let me tell you, insulin injection, whether it's a subcutaneous injection or intramuscular injection or intravenous injection, do not cause a breaking of the Ramadan fast. So people can take injection even before Ramadan iftar. So those who take this iftar dose of insulin, they can take 10 or 15 minutes or 20 minutes before breaking the fast, that is iftar. So that is safe and that will not invalidate the fast. So before going to my presentation, I want to have a case. A 52 years old lady who is a garment business by profession from Kolkata, she presented to my clinic. She had a 12 years history of diabetes mellitus, hypertensive, dyslipidemia. Now she wishes to keep fast during the month of Ramadan in the coming after 1 month. On examination, her vitals are fine. She is little obese. BMI is 27.3 kg per square meter. Her blood glucose parameters are fasting 124 milligram per deciliter. Postprandial blood glucose is 187 milligram per deciliter. HbA1c is 7.5%, and kidney function shows creatinine of 1.1 milligram per deciliter. On inquiry, she is on premix insulin 30/70, 24 unit before breakfast and 16 unit before dinner. She is also on metformin sustained release 1 gram twice daily. She is on sitagliptin 100 milligram once daily. She is on dapagliflozin 10 milligram once daily, and she is also on telmisartan and rosuvastatin. So she want to know whether she should continue insulin during the month of Ramadan. If the answer is yes, then what should be the doses and when that to be taken, and what will be her oral medicines? That she wanted to know. So I would answer at the end of my presentation. So how to adjust the doses of insulin, whether it's a long-acting or short-acting insulin in patients with type 2 diabetes mellitus. So those who are on multiple daily doses of insulin, MDI, the long or intermediate acting basal insulin to be modified like this. If the patient is on once daily NPH or detamir or glargine or degludec insulin, then the dose to be reduced by 15 or 30%. And that to be taken at the evening meal just before iftar, or maybe taken after iftar if it is once daily. If the patient is on long-acting insulin twice a day, the same insulin, NPH, detamir or glargine, then the patient should take the usual morning dose at evening meal, iftar. Remember, the morning dose, that is the before breakfast dose, to be taken at the iftar, that just before the evening meal. And one should reduce the evening dose, that is the before dinner dose, by 50% and to be taken at early morning, just before suhoor. And regarding the short-acting insulin, usually people are being given 3 times before meal insulin, and the normal dose at evening meal to be taken at iftar, that is the before breakfast dose. One may omit the lunchtime dose if the patient is not taking dinner properly, or one may take the lunch dose just before dinner. And one should reduce the early morning dose, that is the suhoor dose, by 25 to 50%, and that should be the before dinner dose. The usual before dinner dose to be taken at the suhoor, and that is to be reduced by 25 to 50% of the daily dose. So what should be the changes to pre-mixed insulin dosing during Ramadan? So people take this pre-mixed insulin dose maybe once daily, maybe twice a day, or sometimes even, but less frequently, we see 3 times daily dosing. So those who are taking once daily dosing, pre-mixed insulin, so that is to be taken the normal dose at evening meal, just before iftar or just after iftar. Or twice daily dosing, those who are taking this pre-mixed insulin, they should take the usual morning dose, that is the before breakfast dose, the same dose with the iftar. And the before dinner dose to be reduced by half, 50% dose to be taken at the time of suhoor. Those who are taking 3 times daily dose, they should omit the afternoon dose and adjust iftar and suhoor dose. They should carry out the dose titration every 2-3 days according to the blood sugar. They should adjust their doses. There are several studies on evaluating insulin treatment in the month of Ramadan and what is the hypoglycemia results. A study by Buchanan et al., it basically, they studied on this glargine insulin, and they found no significant incidence of hypoglycemia. And glycemic control was also not different between the two groups, those who are on glargine insulin or oral hypoglycemic agents. A recent study by Hasnain et al. Basically compared this glargine 300 on more than 1,200 patients. This is a multi-country study, multi-centric study, and basically it showed that proportion of individuals with confirmed hypoglycemia during Ramadan was only 1.6%. In all assessment periods before, during, and after Ramadan, it was 1.7%. So during Ramadan, the incidence of hypoglycemia is 1.6%, and after Ramadan, it was 1.7%. So almost same. So there were no severe cases of hypoglycemia during or after Ramadan. The glycemic control was also comparable, 7.5% and 7.2%. And body weight was seen to decrease by 0.5 kg. So what about the co-formulation insulin during the month of Ramadan? So this is an important study by the same author, Hasnain et al. They basically randomized people of type 2 diabetes on insulin diclofenac aspart and biphasic insulin aspart. And they have a treatment initiation period, then Ramadan period, and post-Ramadan period. And they included only type 2 diabetic subjects, adult, HbA1c of 7 to 10%, and willing to give blood during Ramadan. And what was the result? The result was regarding glycemic parameters, insulin diclofenac aspart and biphasic insulin aspart are similar regarding glycemic parameters. HbA1c are equivalent. Total daily insulin dose are also same in both the groups. However, there is significantly lower incidence of hypoglycemia with insulin diclofenac aspart and significantly lower nocturnal confirmed hypoglycemia with insulin diclofenac aspart group. So insulin diclofenac aspart group is better in relation to hypoglycemia, although this is a bit costly, so many of our diabetic subjects may not afford. So how to adjust the doses of premixed insulin in people with diabetes who are doing fast? Dr. Faria showed nicely what are the time one should check the blood glucose. So if the fasting or pre-iftar or pre-suhoor blood glucose is between 90 to 126, then the same dose to be continued. If it is below 70, then dose to be reduced by 4 units. It's 70 to 90, then reduced by 2 units. If blood glucose between 126 to 200, one may adjust by increasing 2 units of the premix insulin. If it is more than 200, fasting or pre-iftar blood glucose, then one may increase by 4 units. So coming to our case, the 52 years lady, type 2 diabetic for 12 years, hypertensive, dyslipidemic, obese, with a reasonable glycemic control, normal kidney function, on premix insulin 24 and 16, 2 gram metformin per day, sitagliptin 100 milligram, dapagliflozin, and telmisartan and rosuvastatin. So her question was whether she should continue insulin or not. Yes, the answer is yes, she may continue the insulin or she need to continue the insulin. Then the second question is what should be the doses and what will be her oral medicines. So injection premix insulin, what she was taking 24 unit before breakfast, the same dose to be taken subcutaneously just before iftar, and 50% dose of her before dinner dose, that is 8 unit, to be taken subcutaneously before suhoor. Her oral medications to be continued. Metformin sustained release 1 gram after iftar and 1 gram after suhoor may be continued. Sitagliptin and dapagliflozin to be continued after iftar, and telmisartan and rosuvastatin to be continued. So coming to Ramadan fasting dose adjustments for MDI therapy in adolescents with type 1 diabetes mellitus. Usually type 1 diabetes mellitus, they are put on MDI doses, multiple daily doses. The basal insulin, they are a single daily dose basal insulin usually, and the basal insulin dose to be reduced by 30 to 40%, and that is to be taken at iftar. Regarding bolus doses, normal dose to be taken at iftar, and one should reduce the suhoor dose by 25 to 50%, and one should skip the lunchtime dose. As with adults, adolescents with type 1 diabetes, usually we do not promote them, but still few of the adolescents or adult patients with type 1 diabetes, they decide to fast. And their parents must be aware of all potential risks associated with Ramadan fasting. There is some evidence to suggest that as long as they are otherwise stable and healthy, they can do the fasting so safely. However, strict medical supervision and focused education on how to control their glycemic levels is essential. Many people of type 1 diabetes or advanced type 2 diabetes may require insulin pump therapy. So how to adjust the insulin pump? So we know the insulin pump has two types of control. One is basal rate control and bolus rate control. Regarding basal rate, one should reduce the dose by 20 to 40% in the last 3 to 4 hours of fasting, means just before iftar. 3 to 4 hours prior to iftar, one should reduce the dose of basal rate by 20 to 40%. And one may require to increase the dose by 0 to 30% early after iftar for 1 to 2 hours because of heavy meal or feasting. Regarding the bolus rate, one should count the carbohydrate, and normal carbohydrate counting and insulin sensitivity principles apply for them. So they should have a post-Ramadan follow-up. Patients with diabetes should be made aware of the risk of overindulgence after Ramadan, and post-Ramadan follow-up meeting with healthcare physicians is advisable. Educating patient on treatment changes and blood glucose control is necessary. Thank you all. Thanks for kind attention.
Yeah, that was excellent, both of you.
Yes,
And I think if we have any questions in the chat box, Hamid, are you there? Sheila?
It's just logged off for some time, ma'am. But
no worries, no worries.
Thank you very much, Saqib and Hamad both. And that was a fantastic presentation, very, very lucid. And I think one of the most important parts of management of patients during Ramadan, because most of them will come to you for adjustment of either the medication or insulin. Saqib, I had one quick question for you and one quick question for you. It's Hamadur, right? How do I pronounce it, Hamadur? Hamadur is fine?
Hamadur Rahman. Yes, ma'am. Hamadur Rahman.
Thank Hamadur Rahman. Okay. Saqib, I had one quick question for you. We are now, a lot of our patients are on oral semaglutide, and Ramzan is coming up. And now the issue is, how do we readjust? I mean, what advice do we give them? Do they have the medicine at suhoor? Do they have it before iftar? What should we tell them? Patients want oral semaglutide at this point of time and who are going to be fasting during Ramadan. Because this is now the new drug which, a number of our patients are taking and are going to fast.
So we know that especially if we are going to start, it is not a good option to it, but those who are on stable dosage of Ribelsis, so we know that we cannot take anything after that, and it would have to be followed. So the only option which we are having is that the patient can take between the iftar and the dinner time. So like I have some patient to whom I explain that you will have to have, like, if you are taking iftar meal at suppose at 7 p.m. and you are taking dinner at 10 p.m., then you can take it at 8:30 p.m. or so that you can have the maximum gap. Or if you are getting up early in the suhoor time, then you can take it, and then you will have to wait for at least this much of duration, and you will have to take it with only this much of water, which would be difficult. If those patients are not able to maintain it, then I counsel them even before the Ramadan period that we can switch back to other options, and then for the sake of ease and convenience, then we can continue with other options where the patient would be doing good in terms of glycemic status, and for the sake of other benefits, we can again shift back after the Ramadan period is over. So these are the two options which I usually give.
Okay, one of the options. Sorry, Hamad. Yes, Hamadur Rahman, please go ahead.
Ma'am, those who are on this oral semaglutide, we can advise them to take before suhoor. And the common practice is that people get up a little bit early, and many times they offer this prayer, early morning prayer, tahajjud prayer. So they can take the oral semaglutide and they can keep a gap of 30 minutes. I think this may be feasible with most of our patients.
Okay, one of the options which, sorry ma'am, please go ahead. Sorry.
Yeah, 30 minutes is all you need.
Yes, ma'am.
And you can always have more water later. I mean, you've had that little 250 ml of water with the medicine. And then you can always have more water later. I think the morning option would sound so much more doable. And they're used to it. They used to take it early in the morning. And I think the fundamental principle is not to add any new medication.
Yes, ma'am.
And most of the patients would already be, except for the ones who were started insulin within the last 1 year. They are the ones who need really intensive counseling. Others for years they've carried on and they would continue. They would again just come to you for a little bit of counseling. But all the ones with newer medicines added over the course of the last 1 year before the previous Ramadan are the ones who need counseling. So new medicines. I think that's absolutely relevant, plus the regular monitoring, which Fari has already emphasized. Sorry, Shaila, you wanted to say something.
I was good. The only thing which I thought is worth emphasis is whether they can take it when you break the fast also at that, suppose they find it difficult, they can possibly take the tablet and eat after half an hour. Because
that's about 30 minutes is all you need.
30 minutes is all that we need. Dr. Hamadur Rahman, I have another. You said that patients with type 1 diabetes can fast. We now have a lot of our patients on the insulin pump, and who are again, on closed loop systems, who are finding it much more easier to fast. And the guidelines regarding initially we used to not allow our patients of type 1 diabetes to fast at all. Now the guidelines are gradually changing, and most probably with the better monitoring and with CGMS, we should be able to allow our patients to fast. Having said that, what is the ideal type 1 diabetic patient whom you would actually say, okay, it's okay for you to fast, and whom you would say, no, it's just not okay for you to fast? What kind of patient profile, like if a clinician is looking at a type 1 diabetic patient, like for example, would you say a well-monitored, what would be your, maybe at least 2 or 3 parameters which say, okay, I can allow this patient to fast?
Can I add a question to that?
Yeah,
regarding pregnancy? I would like to know the individual experience of all of you. How many pregnant women have actually requested? Of course, we do have data, but I just still want to know what is your personal experience of women who, I mean, during pregnancy, if they insist on fasting, right?
Ma'am,
So
we strictly don't allow them to fast. We strictly say no, because the Quran also, and we quote the Quran in this. Quran says you do not, pregnant women are exempted from fasting. So we put our foot down. That's one area where at least I personally just put my foot down and say no,
I would do that.
Not allowed to fast, and that's it, period. I mean, and they can compensate for the fast later, ma'am.
Yeah, that's what I thought. That's what I thought. Ramadan allows you to, you know, sort of compensate later. But during the course of all the talks, I did hear mention of, yes, pregnant women actually insisting, which I was a bit perplexed and, of course, worried that, I mean, maybe I'm doing something wrong, but I would definitely not allow it during pregnancy. I'm sorry. Go ahead. Go ahead.
Sarita
I would love to know about
ma'am, whatever said and done, okay, even Muslim belief, you know, say, of course, Ramadan fasting is not compulsory for pregnant women. But I worked in Middle East also. They wanted to observe Ramadan fasting, okay, without okay. And we have seen cases, they don't have any problems, and very hardly or very rarely they will get complications also. So they will, at least, you know, say certain part of our India or other parts also, you can you will get this type of question. Shall I go for Ramadan fasting? Scientifically, it's not needed, but they will observe. And there is not much issues also. What I understood from one of the study, if patient doesn't have insulin, recurring diabetes, probably with a simple OHA, all those things, they can observe Ramadan fasting. There is no issue. But Ramadan, Islam says there is no compulsory the system for them, but they should compensate. That is what's the Islamic policy. Okay.
What about ketones? What you ask them to check their urine for ketones and regularly?
Yeah,
because
no,
urea would be
so in Middle East we used to, and in Kerala, of course, we are not doing. And very interestingly, another interesting data shows if the patient has got diabetes on insulin, those ketone bodies probably is not good. But if the patient is not taking insulin, small amount of insulin, that is not really detrimental for mothers or babies' health. These are the data. Okay. Yeah.
Dr.
Coming to the question.
Something, I think. Sir, Dr. Sheelu wants to add something.
Wants to discuss something.
Sir.
Yeah, go ahead, Sheelu.
Sir, am I audible?
Yes, you are.
Madam, I just wanted to say that the situation in Saudi Arabia and the situation in India is completely different. Whole day, a female who is pregnant or has got gestational diabetes, she is making iftar and seher and food for the kids. Whole day she is busy at home. So we generally advise all these females that they can keep it next year, because our religion or any religion is so flexible that if they are not keeping this year, they can keep it next year. So for the last 30 to 35 years of my experience, during Ramzan, we become so flexible regarding the educating the patients that there are 5 pillars in Islam. So if we stop this by convincing them that you can keep it next time, there are many ways to worship. It is just one way to worship. I think it is better that we can just give a very good information to them, because in India you just see in villages and all those, the whole day they are engaged in making seher, iftar and all those things.
Yeah. So anyway, I think there are different viewpoints across the globe. I'm glad Dr. Jabbar has pointed out, yes, that is the viewpoint. And I have seen data. I have actually seen data of women pregnancy, keeping fast during pregnancy with very few complications. But again, you know, like I think because you have that provision to fast later, it makes so much more sense to not take a risk at that for the baby. And it's 2 lives. We're talking of 2 lives here. Yeah, the first question, Shaila, I think Hamadud wants to answer that.
Yes, ma'am. So coming to type 1 diabetic subjects who wish to fast, we have the risk stratification score for both type 1 and type 2. Those who have a previous episode of ketoacidosis or hyperglycemic crisis. So we do risk stratification. So if it is very high risk, we definitely do them, prohibit them not to go for Ramadan fasting. So coming to your question, practical question. So what are the clinical profile of a type 1 patient whom we may allow to have this diabetes fasting? So adult person, obviously above 18, not children with type 1 diabetes will allow to fast. In my last clinic only, a 10-year-old young girl of type 1 diabetes, she basically asked me, doctor, can I do fast in the coming month of Ramadan? I told, no, beta, please don't do fast right now. So we'll guide you later on. So children will not be allowed, definitely. Adults, those who have very good control, HbA1c may be around 7 to 8% of HbA1c. Those who did not have any episodes of hypoglycemia in the recent past, not very fluctuations in the blood glucose level. Those who are well aware what are the symptoms of hypoglycemia and what are the symptoms of hyperglycemia, and those who are well aware when to break the fast, we may allow them. And then those whose parents or caregivers are well aware of these critical situations of hypoglycemia and hyperglycemia and ketoacidosis, so that they can intervene early. These are the patients whom we may allow, with the proper education and insulin dose modification, we may allow them to go for Ramadan fast.
I totally agree, Dr. Muhammadur Rahman. You got a very important point across, that it's very important to educate a family. It's
Yes.
very important that the caretakers and the families involved in this decision making, because if, I mean, either way, I believe that pre-Ramadan education is not only for the person with diabetes who's living with diabetes fasting, but it's for the entire family, so that then subsequently we will deal with less and less complications. Thank you very much for that. Thanks, Saqib and Dr. Hamadur, for that fantastic those fantastic lectures. Coming to the last, though, I would say one very, very important segment of this entire presentations which we've been having. I'm going to ask the Dr. Amal and Dr. Siddharth to introduce Dr. Shilu Shafiq, and he is going to actually, I need everybody who's listening in to remove their pens and papers and jot down the take-home messages which Dr. Shilu Shafiq is going to talk about. Amal, over to you.
Thank you, ma'am. Thank you, Saqib sir and Hamad sir, for this enlightening talk. Now, coming to the last part of our scientific program, the summary and take-home message that will be by Dr. Shilu Shafiq Siddiqui sir. Sir is the professor endocrinology and director of Rajiv Gandhi Center for Diabetes and Endocrinology.
Can we reflect it? Backend team, sir, slide. Thank you.
Thank you. Sir is professor and the director of Rajiv Gandhi Center for Diabetes and Endocrinology, AMU Aligarh. And sir has authored over 70 research articles, supervised around 130 thesis work. Sir is also presently engaged in different ICMR funded projects, and sir has been honored with the DSI award and the Osler award at the SCCon. Sir is reviewer in many journals, and at present sir is pursuing PhD. So over to you, sir, for a summary of this program.
Can I have my screen sharing?
Yes, just 1 second. Bashir, sir, thank you. Yeah, Dr.
Good evening, everybody. Am I audible?
Yes, you're audible.
Achha.
Yes.
I'm really grateful to the ESI for giving me the opportunity to conclude regarding the Ramadan and the diabetes. I have to conclude whatever the previous speakers have been speaking for the last 2 hours in just 10 to 15 minutes. Though I'll try to make it up. The first picture itself says the use of dates at the iftar. I would like to convey that most of the iftar you just see, other than the iftar, they keep on taking the khajurs. But during iftar, nobody takes khajur more than one. They are more concerned regarding taking pakodis and oily foods and taking many vegetables, fruits, and all those things. So regarding dates, we can take just one. That is more than sufficient. Though it has, then regarding the 5 pillars of Islam, just a bit of it, that there are 5 pillars of Islam, and the most, this Ramadan has been made as a 4th pillar and Hajj as a 5th pillar. So Ramadan has been kept as the 4th pillar. The roof can be sustained with the first 3 or the 4th, 5th pillar. So Ramadan, if you have a lot of complications, it is by our religion that you can miss Ramzan if you have one or the other problems, and which is very grave. Regarding the effect of fasting, it is spiritual, physical, mental, social, and potential health benefits. As far as spiritual is concerned, if whatever you want to explain, it is you can explain in this month, because they are mentally free and acceptable to these patients. Whatever you will say, they will accept it, especially in this month of Ramadan. Regarding the potential health benefits, we all know that fasting could lead to anti-cancerous and anti-proteomic signatures, upgrade key regulatory proteins, glucose, lipid, fat metabolism, circadian clock is upgraded, DNA repair is there, cytoskeletal remodeling is there, immune system is a booster, improves cognitive functions, and epigenetic changes. We have, in fact, we are trying to see what are the epigenetic changes starting during Ramzan and post Ramzan, though it is a very short period, but the consumption of oil and the high quantity of oil is used. You will not find the amount of this oil which is used in these months is much more than which is used throughout the year. Regarding this, it is generally being divided like in 3 phases. What you do, you have intermittent fast, total restrictive fast, all these types of fast, and they have different action on our bodies. So this is the presentation how the fast helps us in improving our body build-up. Educators should be precisely educated. I repeatedly tell all these who are educating the people in the villages what to eat, what not to eat. We are responsible to educate the people who educate the patients. Unless the patient is well educated regarding the Ramadan guidelines, it is very precise to tell all those who are educating, because they give false information and that is transmitted, what is to be eaten, what is not to be eaten. So those who are just educating these people in the villages, they should be thoroughly educated. So education pre-Ramzan, during Ramzan, post-Ramzan, everything has been explained in the last 2 hours. We will start with pre-Ramzan, that it should be every medicine, every diet should be personalized. The doses of insulin, the how much you can keep the medications regarding the HbA1c, the body metabolism itself is different from different person. And this pre-Ramzan counseling should ideally be started at least 8 weeks prior to Ramadan, because they have to come to you just prior to Ramzan also 4 to 5 days. Then you may change the medicines who are not responding to the patient. And the pre-Ramzan and Ramzan are totally different. Your metabolism will change drastically during Ramzan, because you are getting up and your melatonin and all those things, all your circadian rhythm is disturbed. So your protein, fat, carbohydrate metabolism also changes. Then regarding the exercise, diet, drugs, recognizing hypo and hyperglycemia, and when to break the fast. This is very important to be educated. Exercise, we have all discussed that Taraweeh is a very complete exercise. So we should attend the mosque instead of those mosques which complete the Taraweeh in 1 to 10 days. We should try those who have diabetes to go to a mosque where Taraweehs are completed in a month, not in a mosque where Taraweehs are completed in 1 to 10 days. And I tell you, this Taraweeh are a complete exercise. There is no need of any exercise because standing for Taraweeh with full concentration, it is as good as full exercise. Avoid iftar parties because that is not totally at your home. Your family prepares food for you differently, and it is the most of the people attending iftar party daily. In the iftar party that is not made for you. They make different variety of and cold drinks and all those things and are there. So you generally avoid iftar parties. Then the dental hygiene. It is very important. It is very difficult to regulate your dental hygiene. So dental hygiene is one which we have been missing, and we should advise the patients to have a very good dental hygiene during Ramadan. Diet. Ideally, what we prefer in iftar, we take dinner along with iftar. So we should take iftar and then the dinner after 3 or 4 hours and then the suroor. So we should not add these together because most of us add these together. We should keep a pace between these two. And iftar also, when your Maghrib namaz starts, the namaz after the siren or starting the iftar, there should be a gap between the prayer time and the iftar so that one can take properly the iftar. So in most of the places, the iftar time and the Maghrib prayers, they have a gap in between. And it is told to these Maulanas that there should be a gap between iftar and the Maghrib prayer so that one can take iftar properly. And there should be a time period between iftar and the dinner. Regarding the iftar period, we should ideally take simple carbohydrate or monosaccharides and disaccharides to provide immediate energy. While at suroor, we should take proper amount of proteins and polysaccharides that can sustain energy release over an extended period. The diet we know should be customized, but we add carbohydrate 30 grams daily, fiber ranging from 20 to 30, and proteins 20 to 30, and lipids making it 30 to 35% of overall calorie consumption. This is the patient should be given food that have a low calorie glycemic or glycemic index or load and its importance. This chart should be distributed to most of the patients that what are the things with low calorie intake, especially just during prior to Ramzan and after the Friday prayers. This chart along with the schedule of the Ramzan should be distributed to the patients so that they can see and adjust according to the diet plan which has a least glycemic index, and they should follow according to this chart as we have the timetable for the Aftar and Seher and all those periods. So this chart and the Aftar chart should be given simultaneously to the patients. Insulin modification as per the patient need, and 6 to 8 weeks prior to Ramzan, we have started changing the patients from SGLT2 inhibitors to sulfonylureas or other drugs. Because we have seen, especially in summers during Ramzan, SGLT2 incidence of UTI and dehydration and difficult to tolerate. SGLT2 we generally change to sulfonylureas or other drugs, but we avoid giving them SGLT2 inhibitors during Ramzan because the duration of dehydration or in not taking oral fluids for the last 16 hours, it is really very difficult, especially in summers. So we generally tell the patients to shift from SGLT2 inhibitors to sulfonylureas or other drugs because metformin and sulfonylureas, they are already taking in these patients. Regarding the preparedness for the Ramzan, for a diabetic patient if we send the messages to the mosque, to the Maulanas, that you just inform regarding the importance of counseling prior to Ramzan, then they are the patients who are diabetic and those who are not well educated, they are able to accept. Instead, we are explaining. These Maulanas, if they explain, they will learn more and understand more. To me, it seems that here in Aligarh, we just give it to Maulanas and tell them that you explain these things and the people will accept more than what we explain them. Regarding the type of monitoring glucose, I think we generally advise them 2 to 3 hours prior to iftar, the blood sugar monitoring. I think it is sufficient. CGM we do prescribe and the patients are there during Ramzan, but just testing once a day is sufficient. And the Maulanas have also given fatwa that glucose testing during Ramzan is acceptable. So we ideally ask them 2 to 3 hours or at 3 to 4 or 5 p.m. just glucose testing is sufficient. Instead of 7 times 3 to 4 days starting, we advise just once a day. Regarding the patient at risk with severe comorbidities, we generally tell them that you can keep fast next year if you have diabetic foot or severe cardiovascular stroke or late stages of CKD. There are very ways to worship. So we generally tell these patients that you can prefer namaz, which is more important or equally important, but as per the circumstances, a patient with serum creatinine and all these medications, he is insisting, we are the doctors, we can counsel them. Similarly, with the patient, I have told you earlier also, patient with gestational or frank diabetes, with fluctuations in blood sugar levels, we are the people who can convince them that you can follow these practices next year. And it is the God or Allah who can forgive us, and He understands our circumstances. These are the post-Ramzan guidelines that what diet is to be taken after Ramzan. I can assure you there is less fluctuation of blood sugar during Ramzan as compared to post-Ramzan. If you see the triglycerides of the patients, they are sky high. So telling them for consumption of lipids or oils is as important as convincing them to have a normal blood sugar or normal diet or proper diet during Ramzan as the consumption of oil. Because they just, everywhere you go in these markets, there are pakodis and all types of oily foods are available. And everybody starts with these oily foods instead of normal diet which they should take during Ramazan. So I would like to just say in the end that the tailor-made plan is very important. Communication between the physician and the patient who wants to keep the fast, this is very important. And the plan which we have to make should be made 6 to 8 or 10 weeks prior, so that we can see 3 to 4 days prior to Ramzan how the patient is behaving by the shifting of the drugs, by the convincing them how they are behaving, how they are accepting what we are saying. This is very important. The education is very important in the patient with diabetes. Thank you all very much.
Thank you, Dr. Shilu Shafiq. I think nobody else could have summarized it as well as you, with your unique style and your unique additions. And I still remember the conversation I had with you where you said that we call it Ramzan. We do call it Ramzan even now in Mumbai also. But so that was a big thank you, and I really appreciate your entire summarizing, and of course with all the additional points that you spoke about. Bajaj ma'am wants to add something. Ma'am, please.
Actually, more of a question. See, Shilu, I agree with you about the intake of fluids and all with SGLT2 inhibitors. But since, at least in India, I'm not talking of controlled environments where you're working in a controlled temperature, right? Where air conditioning is available 24/7 or central heating is available. But in India, Ramadan will march through the year. I think it advances by 11 days and it continues like that. So even, I mean, like this fluid restriction, or I beg your pardon, the fluid loss that we are worried about with SGLT2 inhibitors would be more worrisome during the summers, right? But what about winters? Would you really be wary? Would you really worry? I mean, I wouldn't like to discontinue SGLT2. What I'm saying is, you on a controlled patient with blood glucose within acceptable, decent limits, if you all of a sudden withdraw the SGLT2 inhibitor, right? What would happen to can you predict what would happen? And hyperglycemia again, we are trying to walk a tightrope here. So I would personally, even scientifically, be wary of discontinuing a drug and, switching on to or increasing the SU.
Madam, we discontinue the drug 8 to 10 weeks earlier so that we can assess the side effects and the beneficial effects within this 6 to 8 weeks prior to Ramadan. And
if your patient is good enough to come to you.
Yes, madam, they do come because they have to keep the fast. So they definitely come before the Ramadan. Sir,
Yeah,
our blood sugar is like this. What should we do? And regarding the change of summer to winter, during our lifetime in winters, this Ramadan has come just once or twice. It is predominantly in summers. I don't know about European countries, how this things change, but especially in country of ours, most of the time we have seen Ramzan in summers.
Again, it's hypothetical if the patient comes to you 1 week or 10 days prior. Then would you reconsider or would you still also again?
Definitely, madam, because it takes a longer time to readjust.
Yeah.
So we have started prepare. We make a camp 2 months earlier. We start giving mobile numbers of our dietitian to the patients who are on Ramzan. Their mobile numbers are provided to all the patients that any problem or any variation in your blood sugar level fluctuation, you can contact these mobile numbers. Our dietitians are there. Excellent. Round the clock. At 11 o'clock also they attend the patients.
That's excellent. I think that's wonderful. That's wonderful. Yeah.
Ma'am, if there are no further questions, I think either way we have really overshot time. And I really appreciate the fact that everybody is still logged in. I can, with the madam's permission and Dr. Jabbar's permission, can I give a vote of thanks and can we call it a day?
Just one question, Sheila. Is it available on all this? Is it available on YouTube or any other media? Because
yes,
I think it's been excellent.
Yes,
you must have a...
Ma'am, it will be available on the ESI website. It will go in on the ESI website, ma'am.
Can patients log in there?
Ma'am, this is more geared for physicians. So this is not actually as a patient education program. But what Dr. Jabbar also was contemplating is doing an FB program and doing this live maybe over the next 2-3 weeks for patients.
Excellent.
So we will be planning, hopefully we should be able to come out with that flyer in 4 to 5 days, where we will be having a patient targeted FB program, sir. Ma'am, that was what his thought process was.
Great.
So that will be the next thing, ma'am.
Great. Dr. Jabbar's thinking and vision is truly good, truly great.
Before Shaila take over, in fact, we were thinking about this program, and Dr. Shaila was in Saudi Arabia for a religious pilgrim, and subsequently, I think she got only 3 to 4 days to organize this meeting. I know Dr. very well, excellent organizer, there is no doubt about that. right? You could make it a fabulous show today and this program. I wanted to congratulate Dr. Shaila Sheikh for arranging such a beautiful meeting. Okay, all the way from Shaila. Okay.
Thank you very much. I think it was possible because everybody agreed just with a phone call. I just did a single phone call to ma'am, and ma'am, as usual, with her complete grace, agreed. Dr. Faria, Dr. Saqib, Dr. Umesh, Dr. S.K. Singh sir, Dr. Sheelu, and of course to my two lovely kids over here, Amal and Siddharth. Everybody agreed just at a phone call. So I really appreciate that. A big thank you to each and every one of you who have taken out the time today to be a part of this educational symposium. I know it is going to make a difference to all the patients who are going to be fasting, and I think it contributes to our purpose of life when we have these programs which help our patients do better. So, big thank you to everybody. A big thank you to the backend team for giving me the kind of support they've always given, and a big thank you to everybody who's logged in. A quick reminder, we are having the second part of this program, which is going to be dealing with comorbidities, with specific situations, with cardiovascular disease, renal disease, a lot of more fine tuning, which we need, our patients require on 24th, same time. Please do log in. Please do make it as successful as you have done today. And if there are any questions, you can direct it to the ESI website. We would be more than happy to answer, to get back to you as to whichever query you have. Thank you very much. A big thank you to everybody.
Great learning experience. Thank you so much. It's been lovely meeting all of you and listening to you. It's wonderful, wonderful. Thank you. And my sincerest apologies for joining late.
No,
Again,
ma'am, not at all. You were on time. Thank you, ma'am.
Thanks.
Sheelu, Faria, Saqib, Amal, Umesh, Ritika, Dr. Singh. Wonderful, wonderful, wonderful.
Thank you, ma'am. Thank you, Shaila. Ma'am,
Thank you, madam.
Thank you, sir. Thank you, Sarita Bajaj, ma'am.
Thank
And
you, madam.
good night to all of you, ma'am.
Good night.
Dr. Jabbar.
Good night.
Where was the cake?
Ma'am, sir left. The cake is, he just messaged to me, Bashir, ke sir has left. How will we cut the cake? It's here.
And if we can cut it for him, since it's virtual. Yeah, go happy birthday to you. Where is that song?
Because we kept it ready, but before I could say that, Dr. Chapman left.
Thank you, everybody.
Thank you, ma'am.
Thank you. Thank you, everyone. Thank you.
Thank you.
Bye-bye. Good night. Good
Thank
night.
you.
Good night, ma'am. Good night, everyone. Good night. Good night, sir.
बंद कर